Hi, my dear friends. Right, beta. So now I hope you had something, and now let's proceed. We were actually talking about the Bezos before the lunch break. Just to quickly remind you that Bezos simply means the bag, and sometimes we can find hairs inside the stomach, sometimes vegetable matter, sometimes milk products inside the stomach. When there are hairs in the stomach, we call it as trichobezoar, right? You can even have a look at various other images of trichobezoar, like so. These are the different images, how it can look like. Probably this was the image what we had in the last exam, and the students' feedback was that they were able to see the hairs coming out from this. Basically, what you are seeing here, this is not the stomach as such. This is just a collection of hairs in the shape of the stomach. And this story is commonly seen in those females who keep on plucking their hairs, some psychiatric problem. Or in earlier days, what used to happen, these when we did not have the endoscopy, then many a times what used to happen, these girls used to swallow their hairs, and many a times they presented with vomiting, and in the vomiting the hairs used to come out, and that is how we used to come to know, oh my god, she is having a psychiatric issue, she is swallowing the hairs. And I do remember in the earlier days when no endoscopic facilities were there, then sometimes these girls presented with huge amount of hair collection inside the stomach, and sometimes that could have led to gastric outlet obstruction. And if there is a complete traffic jam situation at the pylorus, you can understand the proximal stomach would be dilated and the girl would be vomiting hairs like anything. And if there is a gastric outlet obstruction, that is something like an emergency situation where the surgeons had to do an emergency laparotomy, and then they used to open the stomach and they used to remove this, what you are seeing on the screen, from the stomach. This is not the stomach which has been removed. This is actually the hairs which have been removed, and they are in the shape of the stomach. So definitely these patients will require psychiatrist consultation. The story of phyto and lactobacillus is something related to stasis inside the stomach. Whenever the stomach movements will slow down, either because of prolonged immobilization, what we see in patients admitted in ICU for long period of time, or maybe if we have done some surgery where we have chopped the motor fibers of the vagus, then the motility of the stomach will be slowing down. Right, beta. The last thing in this stomach duodenal area, is bariatric surgery, which is in fashion nowadays. We all know there are so many things available in the market for this bariatric surgery, or not the bariatric surgery per se, but to reduce weight. There are so many things which are available in the market. And when you are moving on the roads or in your day-to-day life, you see something or the other which is focusing on how to reduce weight. मोटापा जो है वो एक बीमारी की तरह है. मोटापे से एसोसिएटेड बहुत बीमारियां हैं. There are so many diseases associated with obesity. When you are moving on the road, sometimes you see a banner at the back of the auto that there's a lady with a photograph of huge weight, and then something was given, and then the weight reduced. Maybe some capsule was given or some powder was given or something like that. When we are moving in the flights, we find people wearing the badges, lose weight now, ask me how. Sometimes when we are reading the newspapers early in the morning, then we see an advertisement of some gymming center or slimming center, that when the patient came to them, the patient was this much in weight, and now they have done some gymming and now the weight has been reduced like this. Actually, how they publicize is, they take the photograph from the front first with a huge abdomen, and then they take the photograph from the side, right? So that is how these are the marketing stunts. When we switch on the television at 11 o'clock in the night, suddenly we see there is a sauna belt coming up, and that sauna belt is helping in reducing the weight. So there are so many things available. For example, if suppose somebody wants to lose weight by gymming, right? Now what will happen? Suppose 25-year-old, 27-year-old, 28-year-old girl or a boy, he or she feels that he or she is overweight and she wants to reduce the weight. So probably she has entered into some new relationship, right, with a new boyfriend or a girlfriend, and she's quite pumped up, quite motivated, right? So he or she starts hitting the gym. Suppose, let us imagine the story of a boy who has had a new relationship with a girl, and now the boy is quite motivated to reduce the weight. He's hitting the gymming center 1 hour, 2 hours, 3 hours every day, and he has started losing weight. He's quite motivated, but then he starts enjoying the gymming and he feels that yes, this is something good, and he's losing good amount of weight. His girlfriend is going to be impressed like anything, so he starts hitting the gym for 5 hours, 6 hours, 7 hours, 8 hours in a day. Now the girlfriend is getting confused what the hell he's doing. If he's spending all the time in the gym, he has no time for me. So maybe after 6 months, 1 year time, when the boy is busy in the gym, the girl might be busy with someone else, and the girl may leave this boyfriend. Now the boyfriend comes to know, oh my God, what has happened? And now the boyfriend loses all the motivation and he stops going to the gym. And then there is a rebound. Then the boy gains weight again. Moral of the story, beta, whatever methods of losing the weight, whether you are using some chia seeds or you are using some gymming or powder or tablet or anything, they will definitely help you till the time you remain focused and dedicated in doing that. But as soon as you lose that commitment or motivation, there is a big rebound, and then you again gain weight like anything. That means all these methods are totally dependent on the patient's motivation. Even the surgeons did a surgery initially, which was actually dependent on the patient's wish. What initially the surgeons did, I'll show you. The surgeons, they created a band. Now, just a moment. What the surgeons actually did initially was they created a band something like this. And now this band, as you can see, was connected to something. This is a port which can be kept beneath the skin. You can put air into this port. If you push air into this port, the band will inflate and the stomach will compress, and only very little amount is going down. But this is patient dependent. Whenever the patient wants to put air, he can put. Whenever the patient wants to remove the air, he can remove. So just imagine the same story of that boyfriend girlfriend. When the relationship started, the boy went and got the surgery done. So he put the air inside, the band inflated, and the stomach compressed. Since very less amount was going down, so the absorption was not proper, so the boy started losing weight. Now suppose the boy is just not doing any wastage of time or something. He has just got a surgery done. So probably he might be enjoying his nice time with the girlfriend. And the relationship might be going on nicely. But maybe due to some reason, maybe something would have happened. And say after 1 year, 2 years, if there is a breakup, then what will happen? The girlfriend will go away. So the boy will lose all the motivation. Then he'll simply put a needle here and he will remove all the air. So this band will be deflated and the stomach will expand. That means even this method of putting a band around the stomach was actually dependent on the patient's wish. So this method also was not very successful. Then the surgeons realized that patient will always be a patient, and if we have to really make the patient lose weight, then we have to do some permanent arrangements. So what the surgeons did was they made the arrangement something like this.
Surgery or weight loss surgery refers to a variety of surgical procedures for treatment of morbid obesity. Obesity is determined by body mass index, BMI, which is calculated as the ratio of body weight over square of body height. The higher the BMI, the higher the extent of obesity. A normal BMI is between 20 and 25. Morbid obesity is diagnosed when the body mass index is 40 or more, or 35 or more if the person also has obesity-related health problems, such as diabetes, sleep apnea, or hypertension. Weight loss is achieved by reducing the size of the stomach. Smaller stomach makes the patient feel full faster, therefore makes it easier to reduce the amount of food intake. Roux-en-Y gastric bypass is the most commonly performed bariatric surgical procedure and is considered the gold standard for weight loss treatment. This procedure involves 2 steps. In step 1, the stomach is divided into 2 parts. One small pouch at the top of the stomach where it is connected to the esophagus, and the rest of the stomach which will be bypassed. The 2 parts are separated and stapled. Step 2 is the rerouting of the intestine. The intestine is cut at about 45 centimeters or 18 inches down from the end of the stomach. The first part of the intestine, the duodenum, will be bypassed. The top end of the second part, the jejunum, is pulled up and connected to the gastric pouch created in step 1. The lower end of the duodenum is reconnected to the jejunum at a lower point. The new configuration has a shape of the letter Y, hence the name of the procedure. Weight loss is achieved by 2 mechanisms. First, the volume of the stomach is now reduced to a small pouch, usually less than 10% of the original volume. The tiny pouch fills up fast after only a small amount of food, sending a signal to the brain that the stomach is full. This generates a feeling of fullness, or satiety, and helps reduce the amount of food intake. Second, because the first part of the intestine, the duodenum, is bypassed, the amount of nutrition absorbed by the body is greatly reduced. In normal digestion, this is where most of the nutrition is absorbed. Malabsorption contributes to the weight loss effect. While the procedure is proven as an efficient long-term weight loss treatment, it associates with significant complication risks. These include leakage along the staple lines and surgical connections, which may lead to infections and abscess formation. stricture and obstruction of the digestive tract due to scar formation, dumping syndrome, nutritional deficiencies, and other general surgical risks due to the complexity of the procedure.
Right, beta. So let us take a look once more at this video.
Bariatric surgery, or weight loss surgery, refers to a variety of surgical procedures for treatment of morbid obesity. Obesity is determined by body mass index, BMI, which is calculated as the ratio of body weight over square of body height. The higher the BMI, the higher the extent of obesity. A normal BMI is between 20 and 25. Morbid obesity is diagnosed when the body mass index is 40 or more, or 35 or more if the person also has obesity-related health problems, such as diabetes, sleep apnea, or hypertension. Weight loss is achieved by reducing the size of the stomach. Smaller stomach makes the patient feel full faster, and therefore makes it easier to reduce the amount of food intake. Roux-en-Y gastric bypass is the most commonly performed bariatric surgical procedure and is considered the gold standard for weight loss treatment. This procedure involves 2 steps. In step 1, the stomach is divided into 2 parts. One small pouch at the top of the stomach where it is connected to the esophagus, and the rest of the stomach which will be bypassed. The 2 parts are separated and stapled. Step 2 is the rerouting of the intestine. The intestine is cut at about 45 centimeters or 18 inches down from the end of the stomach. The first part of the intestine, the duodenum, will be bypassed. The top end of the second part, the jejunum, is pulled up and connected to the gastric pouch created in step 1. The lower end of the duodenum is reconnected to the jejunum at a lower point. The new configuration has a shape of the letter Y, hence the name of the procedure. Weight loss is achieved by 2 mechanisms. First, the volume of the stomach is now reduced to a small pouch, usually less than 10% of the original volume. The tiny pouch fills up fast after only a small amount of food, sending a signal to the brain that the stomach is full. This generates a feeling of fullness, or satiety, and helps reduce the amount of food intake. Second, because the first part of the intestine, the duodenum, is bypassed, the amount of nutrition absorbed by the body is greatly reduced. In normal digestion, this is where most of the nutrition is absorbed. Malabsorption contributes to the weight loss effect. While the procedure is proven as an efficient long-term weight loss treatment, it associates with significant complication risks. These include leakage along the staple lines and surgical connections, which may lead to infections and abscess formation, stricture and obstruction of the digestive tract due to scar formation, dumping syndrome, nutritional deficiencies, and other general surgical risks due to the complexity of the procedure.
So I hope, Ita, we got it nicely that what we are actually doing in this bariatric surgery. The crux of the story is that we are just trying to make this stomach pouch small so that patient feels early satiety. Just after filling this much of stomach, the satiety center will be stimulated and the patient will be feeling full. He won't feel hungry after this. The second thing what we know is we have to connect this with the jejunum. So when we are connecting the jejunum with this, that means we are actually bypassing the absorptive surface area, right? So absorption is not going to occur, and this will also help in losing the weight. That means 2-prong approach. One, reducing the amount going down, and second, whatever is going down, that is also not allowed to absorb properly. Okay? Fine. Now let's take a look at what all is written in the workbook, because this is something, the complications and everything is what we have already discussed earlier. So bariatric surgery, beta, this is the surgery for morbid obesity or the metabolic surgery. The indication for doing this bariatric surgery, if the patient's body mass index, BMI, body mass index, if it is more than 40, or if the body mass index is more than 35 with or without comorbidities. Now what can be the different comorbidities with obesity, beta? diabetes, hypertension, osteoarthritis, sleep apnea syndrome. These are just few examples of various comorbid conditions with obesity, right? So just imagine a 300 kg person whose knees are not able to take up this 300 kg weight, and the knees do not want to work. The knees have developed severe osteoarthritis, and now this patient is also having difficulty even in standing. So definitely we are doing these bariatric surgeries so that these things can be taken care of. Right, beta. Apart from this, we can also do a laparoscopic adjustable gastric banding. The video which we saw, that how we can put a band around the stomach, that is actually a patient dependent method, laparoscopic adjustable gastric banding. We can even do a vertical banded gastroplasty, and we can even do a sleeve gastrectomy. Now in sleeve gastrectomy, beta, it's a very simple procedure. If this is the esophagus and this is the stomach, then we just take the help of a stapler. Suppose I take the help of a linear stapler, and I just take the stapler here, one end in front and the other end behind, and I just keep on firing the stapler something like this. So what I'm going to do, I'm just going to divide the stomach somewhat like this. Now this part of the stomach will be separated and this will remain. So you can see how we have made a sleeve of the stomach here. This is what we call as a sleeve gastrectomy. Okay, so these are the various options for bariatric surgery. Right, beta. So till now, what we have done is we have talked about the story of stomach and duodenum, where we focused on gastritis story, the peptic ulcer story. We focused what can be the different types of gastritis: acute, chronic type A, type B, and the special types of gastritis. Then in peptic ulcers, we saw the duodenal ulcer story, the gastric ulcer story. We saw how these patients present to us, how we approach in the management of these peptic ulcers. Majority of the time, surgery is not required. Just medicines are what are sufficient, like PPIs being the gold standard. If H. pylori is there, then we give eradication therapy. Surgery is usually not needed. But because this is a surgery class, we should know what all surgeries can be done. Plus our MCQ people, they are focusing on the complications of surgery for the stomach. So we discussed the different surgical options. For duodenal ulcer, we have to reduce the acid, so we were doing a highly selective vagotomy. For gastric ulcer, because it can become malignant, so we were removing that part of the stomach which was having the ulcer. We were doing a Roux-en-Y gastrojejunostomy. After doing these gastric surgeries, patient can develop some complications like duodenal stump blowout, dumping syndrome, post-vagotomy diarrhea, nutritional deficiency, gallstone, and gastric cancer. Then we also talked about what can be the complications of peptic ulcer. They can bleed, they can perforate, and they can lead to stenosis. Then we talked about different bezoars, trichophytolactatobezor, and then a passing reference about bariatric surgery. So I hope this stomach duodenum area is done. And now if we take a look at the indexing beta, indexing of the adult surgical problems, in this we are done with the thoracic part. In the thoracic part, first we talked about the dysphagia story, the Zenkus diverticulum, the achalasia cardia, the nutcracker, the diffuse esophageal spasm, the Schatzki's ring, the lie stricture story. Then we talked about the surgical chest pain story, like gastroesophageal reflux disease, that is the retrosternal pain, the complications of GRD, esophagitis, stricture, shortening, Barrett's, and hiatus hernia story. Then we talked about the Bohr-Harvey syndrome, barotrauma, spontaneous rupture of the esophagus, left-sided chest pain radiating to the left shoulder and to the left arm. Then we talked about the iatrogenic esophageal perforation. We talked about the different foreign bodies in the esophagus. Then we came down into the abdomen. Here we talked about the stomach duodenum stories, the gastritis and the peptic ulcer stories, the bezoars, and the bariatric surgery story. So now beta, we are moving into the right hypochondrium, and this area belongs to liver and gallbladder. So let us take a look at what all surgical problems can be there in the liver and gallbladder area. Herein, the bread and butter of a surgeon. सर्जन के बच्चे के स्कूल की फीस इसी इलाके से जाती है. The bread and butter of a general surgeon is laparoscopic cholecystectomy, that is removal of the gallbladder. And removal of the gallbladder is most commonly done for stones inside the gallbladder, which is a very, very common problem, especially in our country. So many females, their gallbladders have been removed. Not only females, yes, also males, but more commonly in females. Let us take a look at what we are going to talk about in this area. First of all, see what we are trying to talk here. These are the stones inside the gallbladder. Sometimes the stone can come at the cystic duct, create a complete traffic jam situation, proximal dilatation, stasis and party, acute inflammation of gallbladder can occur, acute cholecystitis can occur. Okay, so there may be a chronic cholecystitis, acute cholecystitis. Then we'll see that if the stone slips into the common bile duct, it may create a traffic jam situation here. The proximal pupil will dilate, and you know, the patient can have jaundice, steatorrhea, malabsorption. Then we'll see if the stone slips down and blocks the pancreatic duct. Then the pancreatic juice, which is going to travel here, will not be able to travel. Proximal pupil dilated, stasis, party, acute pancreatitis. So I repeat this video beta just for your understanding ki how this gallbladder stone can create different type of problems, and how we are going to study that, what our examiners are interested in. So herein you see there can be stones inside the gallbladder which can lead to mild pain in the right hypochondrium. That is the chronic cholecystitis, the commonest presentation of these stones. If the stone gets stuck at the cystic duct, it can cause proximal dilatation. This will lead to stasis and party, which will lead to acute cholecystitis. The stone can slip into the common bile duct, traffic jam to the passage of bile, proximal pupil dilated, jaundice, bile not coming into the intestine, so fats are not getting digested, steatorrhea, malabsorption. This stone can slip further down and create a traffic jam in the pancreatic duct, proximal pupil getting dilated, stasis, party, acute pancreatitis. So this is how this gallbladder stone can be related to these different problems. Right? Now let's take a look that why these stones form, what actually happens here. Very simple to understand beta. Stones inside the gallbladder, we call them as cholelithiasis. Stones inside the bile duct, we call as choledocholithiasis. Right? So here it is cholelithiasis. We can find three types of stones inside the gallbladder. For that, let us try to have a look at the color of these different types of stones. Acha beta, who produces bile? Liver. And what is the job of gallbladder? Just to store the bile, right? And what is the function of bile? Bile is required for emulsification of fats, which help in digestion of fats. So in gallbladder there is bile, which is responsible for emulsification of fats. Fats means cholesterol, right? Now the stones which we can see inside the gallbladder, they can be of cholesterol stones. Cholesterol. These yellow, makhan bhi Amul butter is yellow, right? So जैसे अमूल मक्खन होता है पीला वैसे पीले जो पत्थर दिखाई दे रहे हैं, these yellow stones, these are cholesterol stones. Apart from this beta, in the gallbladder there are bile pigments, bile salts also, and sometimes we can even find the pigment stones. These are usually green, brown, black in color. These are pigment stones, right? And there are mixed stones. The gray colored stones, what you are seeing, these are mixed, which are having cholesterol as well as pigment. Okay. So let us just try to take a look the different type of stones inside the gallbladder. There are cholesterol, pigment and mixed stones. Cholesterol stones means which contain more than 50% cholesterol. This is cholesterol. If there is more than 50% cholesterol in a stone, then we call them as cholesterol stones. And these are pale yellow in color. Pale yellow in color. They are more common in those countries where people can afford Amul Makhan, or not Amul, but people can afford butter, like rich countries, US and Europe. Pigment stones are those stones, beta, which contain less than 30% of cholesterol. They are green, brown or black. They are more commonly seen in Asian countries. And mixed stones, which contain 30 to 50% of cholesterol, they are gray in color. Now, if we talk about the story of cholesterol stones, the cholesterol stones, they are more commonly seen in fat, fertile female and fatty females who are fertile somewhere around 40 years of age. Why? For this, let us try to understand. This is the normal story what we know, that there is a liver and just beneath the liver there is a gallbladder. There are right and left hepatic ducts, common hepatic duct, cystic duct and the common bile duct which joins with the pancreatic duct. Now inside the gallbladder there are bile salts and bile pigments. These bile salts and bile pigments, suppose this what I am drawing, this is bile salt and bile pigment. Apart from this, beta, there is cholesterol inside the gallbladder. So this bile salt and bile pigment, they keep the cholesterol in a miscible state. If suppose the amount of cholesterol increases, what is going to happen? There is a risk of precipitation of these cholesterol. Or suppose if the concentration of bile salt decreases, then also there will be high risk of precipitation of these cholesterol. So whenever the amount of cholesterol increases or bile salt bile pigment decreases, the chances of precipitation of cholesterol inside will be high, and that will lead to cholesterol stones, right? So here, beta, please make a correction. The arrow marked here, they are just opposite. Increased cholesterol or decreased bile salt or bile acid. Such bile inside the gallbladder is called as lithogenic bile. Litho means stone. Lithogenic, stone banane wala bile. Lithogenic bile or supersaturated bile. Supersaturated bile. Right? So this is one reason for cholesterol stones. Another reason for cholesterol stone is abnormal enterohepatic circulation. Now, beta, I would like you to focus a bit on some more concepts coming up. Suppose this what I have drawn. This is the ascending colon. And here suppose this is the cecum. And here would be lying the appendix. This what we are seeing, this is suppose the terminal ileum. This suppose is the terminal ileum. And we know that the ileum joins into the cecum, ileocecal junction where there is a valve, ileocecal valve. This what you are seeing here. This is the mesentery suppose. Mesentery is having the blood vessels which are supplying blood. There are arteries which are actually bringing the blood. There are veins which are actually draining the blood. Right? We all know this. The job of the artery is to supply, job of the vein is to drain. Now look at me on the screen, beta. All of you who are watching this session right now, you should know that whatever bile salts are here, bile acid, bile salt, all this bile salt, bile acid, when the gallbladder contracts, it passes into the common bile duct, and common bile duct is opening into the second part of duodenum. So bile salt, bile acid comes here. When it is coming here, it goes into the duodenum, jejunum and ileum. When it is coming into the ileum, look at me, 95% of these bile salts and bile acids, they are absorbed into the veins here. Whatever bile salt, bile acid is coming in the intestine, 95% of that is getting reabsorbed by the vein, right? And when this is getting reabsorbed, then where it is going? This part is the midgut, what you are seeing in the GIT, beta. Foregut, midgut, hindgut. Foregut supplied by celiac, midgut superior mesenteric, hindgut inferior mesenteric. Foregut is up to the junction of second and third part of duodenum, or you can say just proximal to the junction of second, third part of duodenum. From third part of duodenum, midgut starts. So third part of duodenum, fourth part of duodenum, jejunum, ileum, cecum, ascending colon and proximal 2/3 of transverse colon. This is the midgut. After the distal 1/3 of transverse colon, the splenic flexure of colon, descending colon, sigmoid colon, this is the hindgut. So this part what you are seeing, beta, the terminal ileum, cecum, ascending colon, this is the midgut part, and this will be supplied by superior mesenteric artery and its branches will be drained by the superior mesenteric vein and its tributaries, right? 95% of bile salt are getting reabsorbed into the superior mesenteric vein. If we take a look at the anatomy there, this, what you are seeing here, this is the superior mesenteric vein, this is the inferior mesenteric vein, this is the splenic vein, and splenic vein and superior mesenteric vein join to form the portal vein. Okay, or if I just make it a little more proper, this is what you're seeing is the superior mesenteric vein, this is the inferior mesenteric vein, this is the splenic vein, and splenic vein and superior mesenteric vein join to form the portal vein. Okay. This is the superior mesenteric vein, this is the inferior mesenteric vein, this is the splenic vein, and this is the portal vein. Now just imagine, beta, just try to create a correlation. Look at me on the screen. Whatever bile salt, bile acid were coming into the duodenum, into the intestine, 95% was getting reabsorbed into the superior mesenteric vein, and superior mesenteric vein is opening into the portal vein. So 95% of bile salt is coming back into the liver, and once this bile salt has come back into the liver will excrete these bile salts into the right and left hepatic ducts. This is the right hepatic duct, this is the left hepatic duct, this is the common hepatic duct, this is the cystic duct, and here would be the common bile duct. That means whatever bile salt and bile acid has come here, that will again be transported through right and left hepatic duct, common hepatic duct, and it will go inside the gallbladder again, right? This is the normal story. आप सब लोगों में बेटा जी क्या हो रहा है, जो भी बाइल सॉल्ट बाइल एसिड है वो यहाँ पे आ रहा है, यहाँ पे आ रहा है, यहाँ से रीएब्जॉर्ब हो रहा है, रीएब्जॉर्ब होने के बाद वो लिवर में आ रहा है, और लिवर से फिर बाइल डक्ट से होता हुआ गॉल ब्लैडर में वापस आ रहा है. मतलब जो जा रहा है वो वापस से गॉल ब्लैडर में आ रहा है. It is because of this. I repeat this once again, beta, in English. Whatever bile salt, bile acid is getting excreted here, that is coming into the duodenum, that is going into the ileum, 95% of this is getting reabsorbed into the superior mesenteric vein. Through this is coming into the portal vein, into the liver, and from there it is getting excreted into right left hepatic duct, common hepatic duct, into the gallbladder. That means whatever was going out, that was actually coming back. That is why the concentration of bile salt, bile acid inside your gallbladder is high. And if the concentration of bile salt, bile acid in your gallbladder is high, it will not allow the cholesterol to precipitate. That is the reason, beta, why you are not suffering from gallstones. Okay? Sometimes, if there is any problem or any traffic jam in the entire tract, what we have discussed, suppose I say, beta, there are diseases which affect the terminal ileum, like tuberculosis of intestine. In TB of the intestine, it is the terminal ileum and the cecum which are commonly involved. Inflammatory bowel diseases, Crohn's disease. Crohn's disease also, the commonest site is terminal ileum and then the cecum. So if this part is getting diseased, अगर मान लीजिए मैं ये कहूँ कि ये वाला जो part है ये खराब हो रहा है, if this part is getting diseased, then what is going to happen? The reabsorption will not occur. That means in TB of the intestine or in Crohn's disease of the intestine, the bile salt reabsorption will not occur. That means the bile salt will not be coming here, the bile salt will not be going here, the amount of bile salt, bile acid in the gallbladder will decrease and the cholesterol precipitation will increase, and then the gallbladder stone chances, stones inside the gallbladder can form, right? So that is how the story is linked with abnormal enterohepatic circulation in diseases of terminal ileum. Now I came to know that why TB can be associated with gallstone, why Crohn's disease can be associated with gallstones. Tuberculosis of intestine, or maybe Crohn's disease, they can also be associated with increased chances of gallbladder stones. Another conceptual story, beta, regarding the pigment stones. Now, pigment is formed due to breakdown of RBC. And beta, can you tell me where in your body the RBCs are broken down mainly? आपके शरीर में RBC कहाँ पे टूटते हैं ज़्यादा? Very good. So RBCs are mainly broken down in the spleen. When the RBCs are breaking down, then obviously the pigments are getting released. So any condition where there is more breakdown of RBC, more pigment will be formed in the spleen. And if the pigment concentration in the spleen increases, what can happen? This pigment from the spleen is going to travel through the splenic vein. This is going to come in the portal vein, in the liver, and then through the left and right hepatic ducts. This is going into the gallbladder. So any patient where there is more breakdown of RBC in the spleen, more pigment production in the spleen, this is going to travel and will go into the gallbladder. More pigment concentration in the gallbladder will have more chances of formation of pigment stones inside the gallbladder. Oh, is it so simple? कितना सिंपल है देखो बेटा, है ना? कोई भी ऐसे हालात जिसमें आरबीसी का ब्रेकडाउन बढ़ेगा तो ज्यादा पिगमेंट बनेगा ना. अगर ज्यादा पिगमेंट बनेगा तो ये पिगमेंट लिवर में जाएगा, लिवर से फिर बाइल डक्ट से होता हुआ ये गॉल ब्लैडर में आएगा, तो गॉल ब्लैडर में ज्यादा पिगमेंट हो जाएगा ना, तो पिगमेंट स्टोन्स के बनने के चांसेस बढ़ जाएंगे. That is the reason why pigment stones in the gallbladder, they are associated with various hemolytic disorders. Right? So pigment stones, they are associated with hemolytic disorders. अब hemolytic disorders में 17th of December को they might give you anything. Maybe hereditary spherocytosis, ऐसा कुछ नाम दे देंगे, या फिर or they might write some sickle cell anemia or something like that. Anything where there is more breakdown of RBC in the spleen, there will be more pigment production. This pigment will be traveling through the splenic vein, portal vein, liver, right left hepatic duct, common hepatic duct, cystic duct, gallbladder. Even parasitic infestations and bacterial infections have been found to be associated with pigment stones. Parasitic infestations like Ascaris, Clonorchis. These are two common parasites found in this area. Bacterial infection, E. coli, is a common culprit. So they can be associated with pigment stones. Now, beta, let us try to take a look at how these different stories can occur. How the patients can present to you, beta, February 23, to understand the clinical presentation. If suppose I say that this is the gallbladder, suppose this is the gallbladder, this is the story. Right. This is the cystic duct. There might be a stone in the gallbladder like this. Patient may not have any problems whatsoever. Sometimes situations like this, patient might have some mild pain off and on in the right upper abdomen. कभी कभी पेट के ऊपरी हिस्से में दाहिनी तरफ मीठा मीठा दर्द होता है. Or sometimes what can happen, there might be a big stone in the gallbladder which might be creating a traffic jam situation at the mouth of the gallbladder. We all understand the concept, beta. Whenever there is a complete traffic jam situation, जब रास्ते में पूरी तरह से रुकावट हो जाएगी, the proximal people are going to get dilated. There would be biliary stasis, which will be an open invitation for the bacterial party. If suppose this what I am drawing is bile, there is biliary stasis here. And now because of stasis, it is an open invitation for the party. So bacterial party can start in this. And if bacterial party starts here, there will be acute inflammation which will cause the entire gallbladder to become acutely inflamed. Red, hot, inflamed gallbladder. This is what is acute cholecystitis. Obviously the presentations in these different scenarios, जो हमें ये तीनों चीजें दिखाई दे रही हैं, patient के presentation भी अलग अलग होंगे. This what we are saying is patient does not have any problems. This we are saying that patient might be coming in the OPD with some mild pain off and on in the right upper abdomen. And this red hot gallbladder, the patient would come in emergency with severe pain in the right hypochondrium or right upper abdomen, radiating to the back, nausea, vomiting, fever, and all that story, right? What we are supposed to do in these different situations, one thing which is very clear to us, that if the patient does not have any problem, we also should not have any problem. We are doctors, we treat patients, we do not treat papers. There would be cases coming to you in your clinical practice, beta. There might be questions coming to you on 17th of December related to this. The patient has come to the hospital for some or the other problem. On investigations, it was detected that she is having some problem at some other area where she is not actually having any discomfort or any pain or anything. Now, should we treat that particular pathology for which the patient does not have any problem? The answer is straight no. If the patient does not have any problem, we also do not have any problems. So, asymptomatic gallbladder stones, what should be done? More than 80% of the patients are asymptomatic. Then why they come to the hospital? Just imagine a clinical scenario, beta, that 35-year-old lady presented to the hospital with lower abdominal pain. पेट के निचले हिस्से में दर्द है. Now she has come to the hospital. She goes to a gynec OPD Gynecologist does the examination. She does a pervaginal examination and she feels that yes, there is tenderness in the pouch of Douglas. She is thinking that probably the lady is having pelvic inflammatory disease, PID. So the gynecologist may ask for an ultrasound of the abdomen. Now, when the radiologist was doing an ultrasound, he would be seeing some changes related to PID. So he'd be writing the report of PID. Plus, sometimes incidentally, when the radiologist keeps the probe in the right hypochondrium, he might come to know that, oh my God, there are stones inside the gallbladder. And then the radiologist will mention in the report that incidental finding of stones in the gallbladder is seen. Now, when this lady goes back to the gynecologist looks at the report. Yes, I was telling this is a case of PID. So for PID, I have to give antibiotics to this lady. Is there anything else? She's having stones in the gallbladder. Oh my God. Then the gynecologist might tell the patient, look, you are having stones also inside your gallbladder. That surgeon is sitting there in that OPD. Go to that surgeon and get your gallbladder removed. The lady looks at the report. The lady looks at herself. I'm having a problem in the lower abdomen. Why should I go to a surgeon and get my gallbladder removed? But because the gynecologist has said, so the lady comes to the surgeon's OPD and the lady gives the report to the surgeon. Sir, please remove my gallbladder. Then the surgeon asks the patient, what is the problem? The lady is telling the lower abdominal pain story. The surgeon is again asking, is there any other problem, ma'am? Are you comfortable? Is there any other problem in any other part of your abdomen? The patient is, no, I don't have any problems. The surgeon is still trying his best to elicit from the history. The surgeon is going into more details. The surgeon has gone into the detailed personal history also. That how many children you have, what is your husband doing, what time the husband goes out of the house, what time the husband comes back in the house. All this personal history has also been asked. But despite all this history, the patient has not told anything which is related to gallstones. No pain in the upper abdomen on the right side. So in these cases, ideally what we should do, we should give the report back to the patient. Look, ma'am, you're not having any problems related to this. Enjoy your life from a surgeon's perspective. No need to get your gallbladder removed. This is the ideal situation. However, if in the ultrasound report there is something mentioned which indicates that this stone inside the gallbladder can complicate, then we will advise the patient to get the gallbladder removed. If there are no evidences to suggest that the lady can have any problem in future related to these stones, we can go ahead with the conservative treatment also. There are certain exceptions where we might have to remove this gallbladder even if the patient is asymptomatic. So, if we are talking about the first scenario, asymptomatic story, generally no treatment is required in these situations. But cholecystectomy is done if there are these 10 points, 1, 2, 3, 4, 5, 6, 7, 8, 9, and then 10. Now, patient is asymptomatic, but suppose there is a single stone in the gallbladder which is more than 3 centimeter in size. We know that if there is a big stone inside the gallbladder, there might be a traffic jam situation very soon, and then the patient will present an emergency. So to avoid that story, let us operate the patient today. If there are multiple stones inside the gallbladder, if you remember, beta, we saw the video just now, that if there are multiple stones, they can slip through the cystic duct, they can come into the common bile duct, and then they can create a traffic jam in the common bile duct leading to cholangitis. So that can be a complication. So we can remove the gallbladder if this is the situation. Elderly people, we do not want to take any chances. Immunocompromised, the risk of infection would be high, like the patient is having HIV or diabetes or something, the risk of infection is high. Pregnancy, we don't want to take a risk for two lives. So preferably we remove the gallbladder in the second trimester of pregnancy, even if the patient is asymptomatic. Typhoid carrier, now Salmonella is the bacteria culprit for typhoid, and Salmonella has a tendency to go into the gallbladder and party inside the gallbladder. So if the lady is a typhoid carrier, the chances of recurrent infections in the gallbladder are high. So we don't want to take any chances, and we can remove the gallbladder if the lady is typhoid carrier, even if she is asymptomatic. Porcelain gallbladder, beta, this is a condition which we are going to read a little later. In this, calcium gets deposited inside the gallbladder, and that can lead to cancer of gallbladder. So we don't want to take any chances here. If there are adenomatous polyps inside the gallbladder which are more than 10 millimeter in size, remember beta, adenoma term anywhere in GIT is a dangerous term because it can lead to cancer. But if the size of the polyp is less than 10 millimeter, means less than 1 centimeter in size, then the chances of this polyp becoming malignant are less. In these patients, we do a serial ultrasound, we do a follow-up ultrasound. Maybe today we have come to know there is a polyp of 5 millimeter in the gallbladder. We can call this lady again after 6 months, do a repeat ultrasound and see whether the size of the polyp has increased or not. But if the size of the polyp is more than 10 millimeter or 1 centimeter, the chances of malignancy are high. So we don't want to take any chances here, and we should remove the gallbladder. Hemolytic disorders, like today the patient might be asymptomatic, but if she is having sickle cell anemia, then we know that pigment production is very high, and these are not going to stop. The chances of recurrent stones in the gallbladder would be high, so we should remove the gallbladder. A patient who has undergone bariatric surgery or a gastric surgery, if you remember beta, in the peptic ulcer surgery, we saw that how the vagal fibers were going towards the gallbladder, and whenever those vagal fibers were chopped, the gallbladder motor contractions reduced. So motility of the gallbladder reduced, stasis of bile inside the gallbladder, risk of infection and stone formation is high. So if the patient has already undergone bariatric surgery and suppose he is detected to be having asymptomatic stones in the gallbladder, then also we should remove the gallbladder. That means beta, these are the 10 indications of removing the gallbladder even if the patient is asymptomatic. Single stone more than 3 centimeter, multiple stones, elderly, immunocompromised, pregnancy, typhoid carrier, porcelain gallbladder, adenomatous polyp more than 10 millimeter in size, hemolytic disorders, or patient who have undergone bariatric surgery. We should remove the gallbladder even if the patient is asymptomatic. If we look at these different indications of cholecystectomy, in asymptomatic patient, there is hardly anything which is left out. So the general dictum and the general practice for stones inside the gallbladder is removal of the gallbladder by laparoscopy, laparoscopic cholecystectomy. That is the reason why when we come to know that a lady is having stone inside the gallbladder, we recommend laparoscopic cholecystectomy in those ladies. Another situation, beta, if suppose the lady is symptomatic, majority of these symptomatic females or symptomatic patients come to us in the OPD, and the general complaint is meeta dard in the right hypochondrium, mild pain off and on in the right hypochondrium, mild pain off and on in the right upper abdomen. Now the actual story, I think I want to explain something here. The actual clinical scenario. You are the doctor, February 23, you are in the OPD, and this lady has come in the OPD. Just imagine a government hospital OPD in India. There would be 100, 200 patients standing in the queue outside. And this lady who is having stones inside the gallbladder, she has come to the hospital in the OPD, means she is not having major issues. She would have come to the hospital with 4 or 5 children. Maybe 2 or 3 are hers, and maybe 1 or 2 are of the neighbors. So all of them have come in the hospital, and the lady is standing in the queue in the OPD, right? When this lady walks inside your chamber and you ask her to sit on the stool, she just tells you that, doctor, sometimes, I feel that there is something in this right side in my upper abdomen. Okay. You ask this lady to lie on the examination couch, the lady on the examination couch, and now you try to feel. You are doing the abdominal palpation. Whenever we have to palpate the abdomen, if the lady tells a problem here, then we start from the opposite area. That means we will start the palpation from this side and we come to the affected area in the end. So you are palpating it here. The lady is comfortable. Then you are palpating here. The lady is comfortable. When you are palpating here, the lady is comfortable. You are looking at the lady is looking at you. The lady is comfortable, and you feel that there is nothing in this lady. Then you try to poke your fingers more, and then the lady might tell you, Doctor, please be gentle. Thoda aaram se. That means there is not much problem to this lady, right? Now, you start thinking that what should be done? A lady with a problem in the right hypochondrium can be due to stone inside the gallbladder. So you can ask for an ultrasound in this lady. You send this patient for an ultrasound. Now, when we do the ultrasound in these females or in these patients, this is what we can see. This is the normal gallbladder. This is the boundary of the gallbladder, what you are seeing nicely. All this inside story is black. Why black? Because fluid appears black on ultrasound. This is a normal gallbladder. This is bile inside the gallbladder, right? If there is a stone inside the gallbladder, this what you are seeing, this is the gallbladder. The stone itself appears hyperechoic. That means stone is brighter. अगर पत्थर है gallbladder में तो ये पत्थर सफेद दिखाई दे रहा है. Stone is hyperechoic, right? Now the thing is whether this is a stone or this is a growth from the wall of the gallbladder. What we can do is we can ask the lady to change her position and then do the ultrasound again. So suppose in supine position you were seeing the gallbladder here. Now you have asked the patient to turn in the left lateral decubitus position, and now you do the ultrasound again. If the stone is mobile inside the gallbladder, the stone will change its position by changing the position of the patient. So that can tell you, ki boss, this is not a growth from the gallbladder. This is a stone. It is moving inside the gallbladder, right? However, even better than this, if it is a growth from the gallbladder, it would have appeared hyperechoic, but you would have been able to see the other tissues also in this area. However, if it is a stone, then the ultrasound waves, they cannot travel through the stone. So you are not able to see anything beneath the stone. I repeat बेटा, अल्ट्रासाउंड जब भी करते हैं ना, तो जो भी पत्थर बॉडी में कहीं भी हो पत्थर, अल्ट्रासाउंड की जो वेव्स हैं, कॉस्टिक वेव्स, वो उस पत्थर को पास नहीं कर पाती. अगर अल्ट्रासाउंड की वेव्स पास नहीं कर पाएंगी बेटा, तो हमें पत्थर के नीचे का हिस्सा नहीं दिखाई देगा. That means the stone will always cast a shadow, a posterior acoustic shadow. अल्ट्रासाउंड जब भी करेंगे, पत्थर कहीं भी होगा, ये हमेशा अपनी काली परछाई छोड़ेगा. And it is with this posterior acoustic shadow we can say with confidence that yes, this is a stone. That is how we can diagnose these stones on ultrasound. And beta, please do remember the gallbladder stones they are usually having cholesterol and not calcium. Because they do not have calcium, they are not visible on X-ray or CT scan. X-ray CT में calcium is seen, but gallbladder stones do not have calcium, they have cholesterol, so they are not seen on X-ray and CT. This is another image, beta. Now here, if you see, can you appreciate this? Now here in what you are seeing, can you appreciate these multiple white shadows inside the gallbladder? And beneath these shadows, beneath these white things, can you see the dark shadows? This is the posterior-acoustic shadow. And it is with the help of these posterior-acoustic shadows we can say that this is a stone. Now this what you are seeing on the screen, beta, again, this is an important image-based question. And my request to all of you, whenever you get any free time, you can do Google and look for ultrasound images of gallstones. As many images as possible, right? This is the gallstone. Herein you can see the posterior-acoustic shadow nicely. This is another image where you can see the multiple posterior-acoustic shadows. इससे अपन पहचान लेते हैं कि हाँ जी ये पत्थर है. Now once the diagnosis has been done, पता चल गया कि this is a stone. The lady is symptomatic, so we should remove the gallbladder. To remove the gallbladder, earlier we were doing open operations. If you go into the 80s, 90s, then I have seen patients with a midline scar, midline laparotomy. And when we asked the history ki bhaiya why this abdomen was opened earlier, then in the history we came to know ki gallbladder was removed. So long back, 50 years back, midline laparotomies were done to remove the gallbladder. Then the surgeons realized कि भैया gallbladder is in the right hypochondrium. Why you are opening here? Open here. Then the incisions for gallbladder operations became subcostal. Subcostal incision is a Cocker's incision. And then we were taking out the gallbladder from this Cocker's incision. Right? Okay. Gradually we realized with the advancement in the technology कि if you are cutting more, the patient has got more pain in the post-op period, post-op stay is more, expenditure is more. So came the laparoscopic surgery. In laparoscopy, we are just creating small holes, putting long instruments and removing the pathology or dealing with the pathology. If you are creating very small holes, the post-operative pain is less, post-op morbidity is less, hospital stay is less, expense is less. So laparoscopic cholecystectomy is the preferred surgery nowadays. In laparoscopic surgery, what we do, beta, this is the laparoscopic operation theater. In this, what you are seeing, this gentleman, he is the anesthetist, right? She is the main surgeon, she is the staff nurse, and she is the assistant, right? Now, what we are doing is, we have created small holes, small holes in the abdomen, right? Like, and through these small holes, we are going to pass long instruments. Can you see these long instruments in of laparoscopy? The long instruments. Why long instruments? Because the distance is more. However, for laparoscopic surgery, since we have to work inside, so we have to create some space inside. And first what we do, we make the incision around the umbilicus and then pass a Veris needle through which we can connect the gas, carbon dioxide gas. As the gas goes inside, the gas is put in the peritoneal cavity. We are creating a pneumoperitoneum. We are pushing carbon dioxide in the peritoneal cavity. So the abdominal wall starts getting lifted up and we get a space to work inside. Now what we are supposed to do to remove the gallbladder? We have to dissect in the Callet's triangle area. Now this what we are seeing, this is the Callet's triangle area. Herein, this is the right lobe of liver, what you are seeing. This what you are seeing, this is the left lobe of liver. This structure what you are seeing, this is the gallbladder. And if you carefully see this area, this is the area of Callet's triangle. You have to do the dissection in this area. Superiorly, this triangle is bounded by inferior surface of liver. Laterally, this triangle is bounded by the body of gallbladder and the cystic duct. And medially, this is bounded by the common hepatic duct. I repeat once again, beta. Superiorly, it is the inferior surface of liver. Laterally, it is the body of gallbladder and the cystic duct. And medially, it is the common hepatic duct. If you further carefully take a look in this, you can see some structure, some artery going into this. This is the cystic artery. That is the artery which is supplying blood to the gallbladder. And there is the lymph node sitting here, which is the cystic lymph node. As a surgeon, beta, we have to do the dissection in this Callet's triangle. We have to ligate the cystic artery by putting clips, 2 clips on this side, 1 clip on this side, chop in between. So cystic artery is divided. Then this is the cystic duct. 1 clip, another clip. So 2 clips on this side, 1 clip on this side, chop in between. That is how you disconnect the gallbladder. And now you just hold this part of the gallbladder, apply some traction, and try to do a diathermy dissection to remove the gallbladder from the liver bed. That is how the gallbladder is removed. Then we take a bag. We pass a bag type of thing from outside to inside. We put the gallbladder in the bag, and then that bag is taken out. That is how with the keyhole incisions we can remove the gallbladder. Laparoscopic cholecystectomy. Right, beta? I repeat this procedure in Hindi also. आजकल जैसा कि हम जानते हैं बेटा कि हम अगर बड़े बड़े इंसिजन्स देंगे तो पेशेंट को ऑपरेशन के बाद बहुत दर्द होता है, और इस दर्द की वजह से पेशेंट का अस्पताल में स्टे बढ़ जाता है, पैसे खर्चा बढ़ जाता है. तो अब हम लोग लैप्रोस्कोपिक सर्जरी करने लगे हैं. लैप्रोस्कोपिक सर्जरी में क्या है बेटा, छोटे छोटे अपन इंसिजन्स देते हैं, छोटे छोटे होल बनाते हैं, उससे लंबे लंबे इंस्ट्रूमेंट डाल के अंदर जो भी सामान निकालना है निकाल सकते हैं. गॉल ब्लैडर निकालने के लिए बेटा जनरली अपन 4 इंसिजन देते छोटे छोटे, अम्बलाइकस के उधर, ज़ेफी स्टर्नम पे, राइट हाइपोकॉन्ड्रियम में और राइट लंबर में. पहले अम्बलाइकस के बाजू में कट लगाते, वहां से एक वीरिस नीडल डालते, उसमें कार्बन डाइऑक्साइड गैस कनेक्ट करते, बटन ऑन करते, कार्बन डाइऑक्साइड जाना शुरू हो जाती है. उस नीडल से कार्बन डाइऑक्साइड पेट के अंदर जा रही है, पेरिटोनियल कैविटी में. पेट ऐसे फूल रहा है गैस से, एंटीरियर एब्डोमिनल वॉल ऐसे ऊपर लिफ्ट होने लगी है. ऐसा करने से फ़ायदा क्या है कि हमें अंदर काम करना है, हाथ चलाने, इंस्ट्रूमेंट चलाने अंदर, तो जगह चाहिए, इसलिए न्यूमोपेरिटोनियम क्रिएट किया है. अभी गॉल ब्लैडर को निकालने के लिए कैलेट्स ट्रायंगल में डिसेक्शन करना होता है. कैलेट्स ट्रायंगल क्या है बेटा, ऊपर की तरफ देखो तो लिवर की इंफीरियर सरफेस, लैटरल साइड पे देखो तो गॉल ब्लैडर की बॉडी और सिस्टिक डक्ट है, और मीडियल साइड पे देखो तो कॉमन हेपेटिक डक्ट है. और इस ट्रायंगल में से आर्टरी जा रही है जिसको अपन सिस्टिक आर्टरी बोलते हैं, जिसपे सिस्टिक लिम्फ नोड होती है, लिम्फ नोड ऑफ लुंड बोलते हैं उसको. ठीक है. गॉल ब्लैडर को डिसेक्ट करने के लिए पहले सिस्टिक आर्टरी पे 2 क्लिप इस तरफ और 1 क्लिप इस तरफ और बीच में से काट देते हैं. फिर सिस्टिक डक्ट पे 2 क्लिप इस तरफ और 1 क्लिप इस तरफ बीच में से काट देते हैं. फिर गॉल ब्लैडर पे ट्रैक्शन लगाते हैं, यहाँ पे ऐसे खींचते, और डायथर्मी से, कॉटरी से गॉल ब्लैडर को लिवर से निकाल लेते हैं. जैसे ही गॉल ब्लैडर निकल गया, फिर बाहर से एक बैग होता है वो अंदर डालते, बैग में गॉल ब्लैडर को डालते, और फिर उस बैग को अपन बाहर निकाल लेते हैं. तो ऐसे लैप्कोली या लैप्रोस्कोपिक कोलिसिस्टेक्टमी करते हैं. ठीक है. अब देख लेते क्या लिखा हुआ बेटा इसमें. investigation of choice, अल्ट्रासाउंड ऑफ द एब्डोमेन। जो पत्थर होता है बेटा वो खुद तो हाइपरिकोइक होता है, वाइट होता है, उसकी जो शेडो होती है वो काली होती है, पोस्टीरियर एकॉस्टिक शेडो। दैट इज हाउ वी कैन लेबल दिस स्टोन। जस्ट टू रिमाइंड यू बेटा, द स्टोन्स विच आर नॉट सीन ऑन एक्सरे, radiolucent stones, those stones which are not seen on X-ray or CT scan in our body are those stones which do not have calcium, and they are remembered by the mnemonic PG में जाएंगे लक्स से नहाएंगे। PG लक्स। P stands for parotid duct, G stands for gallbladder, and this lux is for the urinary stones. These are lysine, uric acid, and xanthine. PG में जाएंगे लक्स से नहाएंगे। These are the stones which are not seen on X-ray or CT scan. Right, beta. Treatment is simple laparoscopic cholecystectomy. For removing the gallbladder, in laparoscopic surgery, we create 4 ports. We use a Veris needle, beta, to pass into the abdomen, and then we use MCQ gas. Now, this question has been asked number of times. Which gas is used in laparoscopy? So, it is carbon dioxide. And then we are doing the dissection in Callet's triangle, beta. Callet's triangle को अगर देखें boundaries को, तो superiorly it is the inferior surface of liver. Superiorly it is the inferior surface of liver. Laterally it is the body of gallbladder and cystic duct. Medially, it is the common hepatic duct. Content of Callet's triangle is cystic artery and cystic lymph node, which is also called as lymph node of Lund. Cystic artery and cystic lymph node of Lund. So that is how we do the dissection. Just to remind you about the Callet's triangle, beta. This is the enlarged form of Callet's, what you can see here. I hope this is nicely visible. Superiorly it is the inferior surface of liver. Laterally it is the body of gallbladder at the cystic duct. And medially it is the common hepatic duct. What is going here? It is the cystic artery and a lymph node sitting here. That is the cystic lymph node, the lymph node of Lund. This is the Callet's triangle. There have been few controversies in the past regarding Callet's triangle, but this is the updated one required for 17th of December. Now another scenario with the gallbladder stone, beta, what we talked about. I hope you are able to write this, beta. कुछ छूटा तो नहीं है? Are you able to write it? Okay. Fine. Now let's talk about another scenario related to these gallstones, and that was if there is a big stone inside the gallbladder. Now, big stone inside the gallbladder, beta, we can very well understand. This might be creating a complete traffic jam situation here, because of which what is going to happen? The gallbladder is going to get distended. What is there inside the gallbladder? Bile. But bile is coming from bile ducts from the liver. If there is a traffic jam here, the bile which is coming here, that bile will not be able to enter inside the gallbladder. Right? That means gallbladder should be contracted, but gallbladder is distended. And the simple reason is gallbladder is having the mucosa and the job of the mucosa beta is to secrete mucus. That means what actually happens in these situations, suppose I say that this is the gallbladder, right? Now what is happening, there is a big stone which is creating a traffic jam here. That means whatever bile is coming from the liver through the right left hepatic ducts, common hepatic duct, it would be going down into the common bile duct nicely, but it is not allowed to enter into the gallbladder. Ab ideally, if bile is not entering into the gallbladder should be contracted. But here we should know beta that gallbladder is lined by mucosa. So mucosa is there which is secreting mucus. If mucus is getting secreted, then because of the traffic jam by the stone, this mucus is not able to come out. So initially bit 2, what happens? The gallbladder gets distended with mucus. Initially तो कहानी ये हो गई. This stage, when the gallbladder is distended with mucus, is called as mucocele of gallbladder. क्या बोलते बेटा इसको? Mucocele of gallbladder, right? Because of stasis of mucus, there is an open invitation for the party, and now the bacterial party will start. Once the bacterial party starts, then yes, this is going to cause acute inflammation of the gallbladder. And because of this acute inflammation of the gallbladder is going to become red hot inflamed. This is called as acute cholecystitis, right? Patient will present with sudden onset of severe pain in the right hypochondrium. Patient comes in the emergency with severe pain in the right hypochondrium, radiating to the back. In the back, it is going to the inferior angle of right scapula, and sometimes it can go to the tip of the right shoulder. Patient is having nausea, maybe vomiting, high-grade fever. Now, when this patient comes to us in emergency, first we try to stabilize these patients. We will start IV antibiotics. We will start the IV fluids. When the patient is getting stabilized, we'll try to do the clinical examination. In clinical examination, we start palpating from the non-tender area, non-pathological area. Now, when you are coming towards the right hypochondrium, just imagine, beta, look at me on the screen. There is a red hot gallbladder which is lying on the inferior surface of liver. If you take your 4 fingers and try to insinuate your 4 fingers beneath the right costal margin and ask the patient to take a deep breath, the patient suddenly catches her breath. This is called as Murphy's sign. Murphy's sign. I repeat this in Hindi beta. जो एक्यूट कोलिसिस्टाइटिस की कहानी है, कारण बेटा एक्यूट कोलिसिस्टाइटिस का कुछ भी हो सकता है. यहाँ पे हम पत्थर की बात कर रहे हैं. एक्यूट कोलिसिस्टाइटिस का मतलब ये गॉल ब्लैडर गुस्से से लाल हो रखा है, सूजा हुआ है. अब इस पेशेंट को यहाँ पे पेट के ऊपर वाले हिस्से में दाईं तरफ बहुत जोरों का दर्द हो रहा है, और ये जो दर्द है ये पीछे की तरफ जा रहा है, ऐसे स्कैपुला का जो इंफीरियर एंगल है इसके नीचे, और कभी कभी ये दर्द ऐसे राइट शोल्डर पे भी जा रहा है. पेशेंट को नोजिया जैसा हो रहा है, उल्टियां हो रही हैं, बुखार हो रहा है. जब ये पेशेंट इमरजेंसी में आई है तो हमें सबसे पहले इसको स्टेबलाइज करना है. हम इसको आईवी एंटीबायोटिक्स दे सकते हैं, आईवी फ्लूइड्स दे सकते हैं, और फिर जब पेशेंट थोड़ी सी सेटल होने लगती है तो अपने को एग्जामिन करना है. पेशेंट की समस्या इस इलाके में है तो हम एग्जामिनेशन यहाँ दूर से करेंगे, और फिर आखिरी में हम उस हिस्से की तरफ आएंगे. अब यहाँ पे बेटा अगर गॉल ब्लैडर है लाल गुस्से में सूजा हुआ जो लिवर के इंफीरियर सरफेस पे लगा हुआ है, तो जब आप अपनी ये 4 उंगली लेंगे और ये 4 उंगली को पेशेंट के राइट कॉस्टल मार्जिन के नीचे लेके जाएंगे. पेशेंट लेटी हुई है, आपकी 4 उंगली पेशेंट के राइट कॉस्टल मार्जिन के नीचे हैं. अब आप पेशेंट से बोलेंगे लंबी सांस लीजिए. As soon as the patient takes a deep breath, suddenly that red hot gallbladder, जो लाल गुस्से से सूजा हुआ गॉल ब्लैडर था, वो आपकी उंगली से टकराएगा, और जैसे ही वो लाल गॉल ब्लैडर किसी से टकराएगा तो पेशेंट को जोरों का दर्द होगा. पेशेंट अपनी सांस रोक लेती है, पेशेंट कैचेस हर ब्रेथ. दिस इज व्हाट इज मर्फी साइन, इसको बोलते हैं बेटा मर्फी साइन। काम की बात बेटा एमसीक्यूज में ध्यान रखना इस बात को, ये जो मर्फी साइन है ना बेटा, ये मर्फी साइन अपने को इमरजेंसी में मिल रहा है जब गॉल ब्लैडर एकदम लाल गुस्से से सूजा हुआ है। मर्फी साइन उस फीमेल में नहीं मिल रहा है जो ओपीडी में आई थी 4-5 बच्चों के साथ, जिसमें बच्चे खेल कूद रहे थे, माँ डांट रही थी बच्चे को, वहां नहीं मिल रहा अपने को मर्फी साइन। आई रिमाइंड दिस बेटा, मर्फी साइन इज सीन व्हेन द गॉल ब्लैडर इज रेड हॉट इन्फ्लेम्ड। Murphy sign is not seen in a lady who came to you in the OPD who was not having any red hot gallbladder, right? Murphy sign is seen in emergency when the lady has presented with severe pain in the right hypochondrium radiating to the back, right? That is because of the red hot gallbladder. MCQ people will try to bluff you. 17th of December, please do remember this. Murphy sign is not seen in OPD. Murphy sign is seen in emergency. In all those cases where the gallbladder is red hot inflamed. Majority of the times this gallbladder is red hot inflamed due to a stone causing complete traffic jam at the mouth of the gallbladder. That is called as acute calculus cholecystitis. Right? However, this gallbladder can become red hot inflamed in another condition also, which is called as acalculous cholecystopathy. In that condition, the gallbladder motor becomes weak. When the muscle contractions of the gallbladder become weak and gallbladder is not able to pump the bile out, if gallbladder is not able to pump the bile out, then there is biliary stasis inside the gallbladder and bacterial party leading to acute infection of the gallbladder, acute cholecystitis. I repeat this in Hindi again बेटा, जो मर्फी साइन अपन ने अभी सीखा है ना बेटा, ये तभी मिलेगा अपने को जब गॉल ब्लैडर गुस्से से लाल सूजा हुआ है, ठीक है। कारण कुछ भी हो सकता है बेटा गॉल ब्लैडर के गुस्सा होने का। गॉल ब्लैडर ऐसा गुस्से से लाल किसी भी कारण से हो सकता है। मोस्ट कॉमनली जो अपने को मिलता है जब कोई पत्थर है गॉल ब्लैडर के अंदर और ये गॉल ब्लैडर के मुंह को जाम कर देता है, तो म्यूकस इकट्ठा हो जाता है जिसमें पार्टी होती है और उसकी वजह से गॉल ब्लैडर में इन्फ्लेमेशन हो रहा है। कभी कभी एक दूसरी हालत भी होती है जिसको अपन बोलते हैं ए कैलकुलस कोलिसिस्टोपैथी। ए कैलकुलस, ए का मतलब एब्सेंट, कैलकुलस मतलब स्टोन। स्टोन नहीं है लेकिन गॉल ब्लैडर गुस्से से लाल है। ऐसा तब हो सकता है जब गॉल ब्लैडर की मोटर खराब हो जाए, गॉल ब्लैडर पंप नहीं कर पा रहा। अगर मान लो कोई भी हालात ऐसे बन गए हैं जिसमें गॉल ब्लैडर की मोटर मूवमेंट्स कम हो गए हैं, जैसे अपन ने थोड़ी देर पहले स्टमक के ऑपरेशन की बात की थी ना, जिसमें अपन ने वेगस के फाइबर्स को काटा था, तो तब गॉल ब्लैडर को सप्लाई रुक गई थी, तो गॉल ब्लैडर के मूवमेंट्स नहीं हो रहे थे, तो बाइल गॉल ब्लैडर से निकल नहीं पा रहा था। तो बाइल की अगर स्टेसिस होगी गॉल ब्लैडर के अंदर तो उसमें इन्फेक्शन होगा और फिर इन्फेक्शन की वजह से पत्थर बन जाएंगे, है ना, वो बाद में बनेंगे। लेकिन पत्थर से पहले भी अगर गॉल ब्लैडर बाइल को पंप नहीं कर पा रहा तो इन्फेक्शन तो हो ही रहा है ना बेटा, तो उसमें भी तो गॉल ब्लैडर गुस्से से लाल सूज जाएगा। उसको बोलते हैं ए कैलकुलस कोलिसिस्टोपैथी, ठीक है। चलो अब ऐसे केस में व्हाट वी आर सपोज्ड टू डू, what actually we are supposed to do in the management of these patients. She has come to us in emergency. There is a severe party going on inside the gallbladder. We need to control the infection, boss. First, we need to stabilize this patient. And many a times we have seen that by giving a combination of heavy antibiotics, we give a cover against gram-positive, gram-negative and anaerobes. If you are giving proper antibiotics to this lady, then the infection is controlled, and once the lady is treated, maybe 5 days, 7 days, abhi what we are doing, we are admitting this lady in the hospital, we are giving IV antibiotics to this lady. 5 to 7 days the party settles down, and then we discharge this patient, right, and we call her back after 3 to 6 weeks when the infection has totally settled. Then we call this patient back and then we remove the gallbladder. This is called as interval cholecystectomy. Interval cholecystectomy. I repeat this in Hindi again, beta. ट्रीटमेंट क्या करना है ऐसी सिचुएशन में? अगर गॉल ब्लैडर गुस्से से लाल है और पार्टी चल रही है गॉल ब्लैडर में, तो अपने को पहले इस पार्टी को कंट्रोल करना है, ठीक है? अभी ऑपरेशन नहीं कर रहे बेटा अपन इसका। पार्टी को कंट्रोल करने के लिए पेशेंट को अस्पताल में भर्ती कर लिया, एंटीबायोटिक लगा रहे हो अच्छी वाली, जिसमें ग्राम पॉजिटिव ग्राम नेगेटिव एनारोब सबको कवर करने के लिए अच्छी एंटीबायोटिक दे रहे हैं। इन एंटीबायोटिक से ये पार्टी जो है 5-7 दिन में कंट्रोल हो जाती है, 5-7 दिन में पेशेंट ठीक हो जाती है। फिर हम पेशेंट की छुट्टी कर देते हैं कि भैया आप घर जाओ, अब आप ठीक हो, घर पे खाओ पियो, घर की हवा वगैरह खाओगी तो और अच्छी हो जाओगी। और फिर एक काम करना, आप 1 महीने बाद या 1.5 महीने बाद वापस अस्पताल आ जाना, क्योंकि फिर हमें आपके गॉल ब्लैडर को निकालना है, ठीक है? ये ऐसी जो कहानी हो रही है, जब हम उस टाइम पे ही ऑपरेशन नहीं कर रहे हैं, पेशेंट को कुछ दिन रुक के बुला रहे हैं, इसको अपन बोलते हैं इंटरवल कोलिसिस्टेक्टमी। अच्छा बेटा, व्हाट इज द रीजन ऑफ नॉट डूइंग कोलिसिस्टेक्टमी इन दिस केस? इफ सपोज you try to remove the gallbladder, this type of gallbladder, there is a risk that you will spill the infection in the peritoneal cavity, number 1. Number 2, whenever there is any acute inflammation in the peritoneal cavity, whether it is the gallbladder or the appendix, there is a omentum which is called as the policeman of the abdomen, right? That omentum is like a curtain which is curtaining the intestines. भगवान ने अपने पेट में एक पर्दा दे रखा है बेटा, जिसको अपन ओमेंटम बोलते हैं। Whenever there is any acute inflammation in the abdomen, whether gallbladder or appendix, this omentum goes towards that inflamed organ and tries to seal that inflamed organ from all sides. This omentum tries to make an envelope around the inflamed organ so that whatever bacterial party is going on, that remain localized in one particular area only. That party should not spread into the peritoneal cavity. That is the whole idea, right? So this is God is doing. As soon as there is any infection inside, whether gallbladder or appendix, gallbladder sends this omentum, and this omentum tries to envelop that inflamed organ so that the party remains confined in one particular area and does not spread to the whole of abdomen, so that the chances of septicemia are not there. Right? That is what God is doing. Many a times in these acute cholecystitis, we find adhesions of the omentum around the gallbladder, and sometimes the neighboring organs also, like the transverse colon or maybe the stomach, duodenum, common bile duct, they also might get adhered to this inflamed gallbladder. Right? कभी कभी क्या होता है बेटा, जो भगवान ने ये ओमेंटम भेजा ना, इस ओमेंटम ने जो भी वो लाल गुस्से से ऑर्गन था उसको चारों तरफ से कवर कर लिया, जिससे जो भी पार्टी चल रही है वो उसी हिस्से में लोकलाइज रहे, पार्टी फैले ना। और कभी कभी क्या होता है, सिर्फ ओमेंटम अकेला नहीं इसको एनवेलप करता, आजू बाजू के जो और ऑर्गन्स होते हैं, ट्रांसवर्स कोलोन है, स्टमक, ड्यूडेनम, सीबीडी, ये सब यहाँ चिपक जाते हैं। इसका मतलब एक्यूट इन्फेक्शंस जब हैं तो काफ़ी चिपका चिपकी हो जाती है। यहाँ पे स्टमक भी चिपक गया है, ट्रांसवर्स कोलोन भी आके चिपक गया है, मोमेंटम भी चिपका हुआ है। इफ देयर आर लॉट ऑफ एडिशंस इन acutely inflamed organ, and if you try to do a surgery in these patients, then you will have to remove these adhesions. ये लोग जो चिपक गए इनको आपको हटाना पड़ेगा। And when you are trying to separate these inflamed organs or the adhered organs, sometimes you might cause injury to these adhered organs. And if there is injury to these adhered organs, the inside story will leak into the peritoneal cavity. Peritonitis can occur. There are so many cases reported, beta, that suppose the transverse colon was adhered to the gallbladder, but the surgeon was quite enthusiastic, and the surgeon said, no, how I will not take the gallbladder out. I will take the gallbladder out in this patient. And sometimes when the surgeon is going inside, when he is looking at the monitor, oh my God, I am not able to see the gallbladder. I am just seeing the transverse colon and the stomach all around. And then the surgeon tries to separate the transverse colon, and maybe he might cause some injury into the transverse colon, which he may not recognize at the time of operation. He thinks that he has done a great job. He has removed the gallbladder. He does not even know that he has perforated the transverse colon. And he comes out of the operation theatre. He calls the attendant, "Aao bhai, kaun hai iske saath?" Now the attendants come and the surgeon is boasting about himself. Ki, "Look, this was a bad gallbladder, but fortunately you came to me. That is why I am able to remove this gallbladder, you know. If you had gone somewhere else, then you don't know what would have happened." The surgeon is boasting like that. The attendants are also listening like this. You are great, and everything. The surgeon does not know what he has actually done. Now the patient is shifted out of the operation theatre. Patient goes into the recovery. Transverse colon is perforated. What is there in the transverse colon? Potty. So gradually, what will happen? This potty will start leaking into the peritoneal cavity. Potty, peritonitis. Right? As soon as the patient develops this peritonitis, which may take maybe 1 day, 2 days time. But if the patient develops peritonitis, potty all over the peritoneal cavity, the patient would be going into septicemia and patient will die. And suddenly on second post-op day, the patient's condition starts deteriorating. Patient is going into shock-like condition. And then the surgeon starts thinking, "Oh my God, what I have done. I might have perforated the transverse colon." And now to save the life of this patient, the surgeon will have to do a laparotomy, do a peritoneal lavage, remove the septic load, and try to save the life of this patient. It is because of this reason, beta, that in these type of situations, when we expect that there are good amount of adhesions, then we do not remove these organs, right? It's better to treat this infection first with antibiotics by admitting the patient for 5 to 7 days, discharge the patient, let all the chipki settle, let all the adhesions settle down. Once the adhesions get cleared off in 3 to 6 weeks time, then you call this patient and then you remove the gallbladder. Very less chances of injury to the surrounding organs. That is how you can minimize the complications in these patients, right? Let's see what all is written here. So in case of emergency, beta, this is usually due to a large stone obstructing the mouth of the gallbladder or maybe the cystic duct. The patient presents with sudden severe right hypochondrial pain radiating to inferior angle of right scapula and sometimes to the tip of right shoulder. Apart from this, patient can have anorexia, nausea, vomiting and fever. In your clinical examination, in acute cholecystitis, we find a Murphy's sign. Please do not confuse Murphy's with McBurney's. McBurney's is seen in acute appendicitis. Murphy's is seen in acute cholecystitis. Ultrasound of the abdomen is the investigation of choice. There is another investigation what we can do whenever there is any confusion, whether there is a stone inside the gallbladder which is causing this, or there is no stone inside the gallbladder which is causing this acute cholecystitis. In these situations, beta, we take the help of HIDA scan. So HIDA scan is done to differentiate acute calculus cholecystitis. Acute calculus cholecystitis means there is a stone inside the gallbladder and that is causing acute inflammation of gallbladder. From A calculus. A means absent. Calculus means stone. Absence of stone. A calculus cholecystopathy Even without a stone, the patient may present with cholecystitis, acute cholecystitis feature. That is what is acalculous cholecystopathy. In the treatment for this acute cholecystitis, beta, the treatment is conservative. We give IV fluids, we give aggressive IV antibiotics. IV antibiotics for 5 to 7 days, and then we discharge these patients with the advice to come back after 3 to 6 weeks. That is called as interval cholecystectomy when you are removing the gallbladder after 3 to 6 weeks. So interval cholecystectomy after 3 to 6 weeks. Now beta, there was a question in yesterday's test which in the morning we were discussing. He will be talking about this maybe late evening or maybe tomorrow. Actually beta, when we are doing appendicectomies, normally in general appendicectomy is done in emergency. So if the question would have been simple appendicectomy, the question would have been appendicectomy belongs to which category of surgical wound? The answer was class 3, that is a emergency GI surgery, that is a contaminated surgery. But sometimes beta, what happens in appendicitis when we'll discuss the same situation like gallbladder, sometimes there is acute inflammation of the appendix, and just imagine beta that patient is living in a remote village. जो appendicitis का मरीज है, मान लो किसी दूर गांव में रहता है. Now that person, that patient goes to the local doctor and local doctor keeps on giving him some medicines. So what God is trying to do, God is trying to send the omentum around the appendix. Omentum forms an envelope around the appendix. Sometimes the small and large intestine also get adhered to that. कभी कभी जो छोटी और बड़ी आते हैं वो भी चिपक जाती हैं उससे. Then it forms a mass in the right iliac fossa. That is called as the appendicular mass. The recommendation in the treatment for appendicular mass, don't remove the appendix now. If you try to remove the appendix in an appendicular mass, you will cause injury to the small or large intestine, and then there will be a risk of peritonitis and boarding and takeoff. So it is better to admit the patient in the hospital, give antibiotics for 5 to 7 days, discharge this patient, let the patient go home. Call this patient again after 3 to 6 weeks when infection and everything has been settled. That means this is interval appendicectomy. This is being done when the infection has been settled. So it becomes an elective GI surgery. You are planning this, you are electing this. So interval appendicectomy is an elective GI surgery. And elective GI surgery comes under class 2 category, clean contaminated. That is why the answer for that question was clean contaminated. Right बेटा? चलिए एक और चीज इसमें देख लेते हैं. Why HIDA scan is done to distinguish acute calculus from acalculous? ध्यान से देखना बेटा, just be careful. Suppose I say कि this is the liver. ठीक है जी, this is the liver what you are seeing here. Now when we are doing a HIDA scan beta, in HIDA we inject the isotope into the peripheral vein and then it travels through the circulation, goes into the liver, excreted by the hepatocytes. Suppose I say that this is the HIDA which is coming from the liver. Now in the liver we know there are right hepatic duct, there are left hepatic duct, like here what we are seeing, something like this. The common hepatic duct, then the cystic duct, then the common bile duct, the right hepatic duct, the left hepatic duct, the common hepatic duct, the cystic duct, and the common bile duct. Right? Now there are two pathologies what we are seeing here. One pathology beta, suppose there is a stone inside the gallbladder, which is a large stone, and this is creating a complete traffic jam situation here. And there is another pathology beta wherein there is motor weakness of the gallbladder wall. Motor weakness of the gallbladder wall. That means the gallbladder wall is not able to contract, not able to pump the bile out. But there is no traffic jam here. The wall is weak, right? This is what will happen here beta. If the bile is not pumped out, there will be biliary stasis. Suppose I use green color for bile. So here there is biliary stasis, right? And stasis will be open invitation for party. So party will start, and that is how the gallbladder will become acutely inflamed. Now to differentiate these two conditions, the best thing is doing a HIDA scan. In HIDA, what we are doing is the isotope is coming into the liver, and through the liver this isotope is going into the right and left hepatic ducts, common hepatic duct. It will be going into the common bile duct into the intestine. Here also beta, this will be coming here like this. This will be going here like this. That's all okay. When this is coming here, it is going into the gallbladder. Will this go into the gallbladder or not? क्या ये gallbladder के अंदर जाएगा बेटा? यहाँ पे पत्थर है बड़ा सा. Because of a big stone, this isotope will not be going inside the gallbladder. So you will not be seeing the isotope here. And what will happen in this case, beta? Here, the isotope is coming. There is no traffic jam, so the isotope will be going inside the gallbladder. But the problem is that gallbladder is not able to contract. So whatever isotope has come inside, that will not be able to pump outside. So you might be seeing persistence of this isotope inside the gallbladder. Despite washout of the isotope from remainder of biliary tree, generally within 60 minutes, whatever is coming here, that automatically goes into the intestine. So after 60 minutes, all this isotope will be gone into the intestine, but the isotope which has come inside the gallbladder might be staying inside the gallbladder. So in one condition, we don't see the isotope in the gallbladder at all. In another condition, we keep on seeing the isotope in the gallbladder. That is how HIDA scan is used to differentiate the cause of acute cholecystitis, whether it is acute calculus or it is acalculus. So when we are doing a HIDA scan, beta, what we find in acute calculus cholecystitis, there is non-visualization of gallbladder. While in acalculus cholecystopathy, there is persistence of isotope within the gallbladder despite washout of isotope from remainder of biliary tree. There are few conditions, beta, which are related to the gallbladder. लिख लिया बेटा? Right. There is a term called as mucocele of gallbladder, beta. This mucocele is simply mucus distension of gallbladder, what we are talking about. Empyema, beta, when the party continues inside the gallbladder. So if the bacterial party is not subsiding with antibiotics, these bacteria can start causing necrosis and pus collection can be seen inside the gallbladder. Pus anywhere inside the body has to be drained. Pus को देख के सर्जन को कुछ होता है. So we have to drain the pus. Whenever we talk about localized collection of pus anywhere inside the body, we have to drain the pus in such a way that we do not spill the pus. So for pus inside the gallbladder, we can make a small cut on the skin. Then under ultrasound guidance, we can put a catheter inside the gallbladder through the skin. and drain all the pus through the catheter outside. This is called as tube cholecystostomy. So if there is pus inside the gallbladder, we are going to put a tube into the gallbladder under ultrasound guidance. This is called as tube cholecystostomy. Tube cholecystostomy. Another condition which can be associated with gallbladder is cholesterosis. Cholesterosis is also called as strawberry gallbladder. This is simply deposition of yellow flakes on the mucosal surface of gallbladder. It is a benign condition. This what you are seeing here. This is the deposition of yellowish flakes on the mucosal surface of gallbladder. This is strawberry gallbladder or cholesterosis. Another condition beta, porcelain gallbladder. This is calcium deposition in the gallbladder and there is very high risk of cancer. If there is calcium inside, then this will be visible on X-ray. अगर हम X-ray लेंगे बेटा और calcium है अंदर तो हमें दिख जाएगा, है ना? So porcelain gallbladder condition will be visible on X-ray. अच्छा, Mirzie's syndrome beta. Now herein I would like to ask you that suppose I say that this is the right hepatic duct, this is the left hepatic duct, this is the common hepatic duct and this is the common bile duct. Acha, suppose I say beta that the story is something like this, that this is the gallbladder here, this is the cystic duct here, and here this is the common hepatic duct, suppose, not like this. Something like this. And suppose I draw the same story here. This is the gallbladder. This is suppose the cystic duct. This is the common hepatic duct. This is the common bile duct. Right? अभी ये बताओ बेटा, if I say कि there is a stone inside the gallbladder, will this cause jaundice? Or if I say that there is a stone in the common bile duct, which out of the two conditions will cause jaundice बेटा? कौन से नंबर की कंडीशन में jaundice होगा? Very good, simple. इसमें होगा ना, because the bile is flowing like this. This is a traffic jam for the flow of bile, so the proximal people will be dilated and the bile will be going into the liver, into the blood, so the patient will have jaundice here. But if this is the story, the bile is flowing like this, if there is no traffic jam, then no jaundice. What is Mirzie's syndrome is when this situation start causing jaundice. अब this situation how it will cause jaundice बेटा, उसके लिए ये बना हुआ है. If you just have a look, sometimes what can happen beta, there is a big stone inside the gallbladder and this stone may be putting pressure on the common hepatic duct from outside. So there is narrowing of the common hepatic duct here. Now there is a biliary obstruction. So now the patient will have jaundice. I hope you can appreciate this. A large stone inside the gallbladder, when it presses on the common hepatic duct, it compresses the common hepatic duct, will not allow the bile to flow down, and this will lead to jaundice. So jaundice due to compression of common hepatic duct by a large gallbladder stone. This is called as Mirzie's syndrome. Right beta? This is a hot MCQ for 17th of December. Mirzie's syndrome. This is jaundice due to compression of common hepatic duct by a large gallbladder stone. jaundice due to compression of common hepatic duct by a large gallbladder stone. So this is putting pressure on the common hepatic duct, right? Okay. Then there is another condition beta which we call as fistula of gallbladder. And fistula is something which we all understand. It is the abnormal relationship between two people. अच्छा बेटा एक चीज बताओ, जो ये रिश्ते बनते हैं, abnormal रिश्ते जो दो लोगों के बीच में बनते हैं, ये किन में बनने के चांसेस ज्यादा होते हैं? जो आसपास रहते हैं उनमें या जो दूर दूर रहते हैं उनमें? These abnormal relationships, they are more frequent in the people who are living near to each other or people who are living far from each other? Commonly, yes, you're right. People who are living close to each other, near to each other, है ना? So this is the gallbladder. This is the duodenum, suppose. Sometimes what can happen beta, if there is a large stone inside the gallbladder, this large stone, this might start putting pressure on the gallbladder wall, may cause necrosis of the gallbladder wall, then it may start putting pressure on the duodenal wall and may erode the duodenal wall. If this happens, then an abnormal relationship will develop between the gallbladder and the duodenum. If we take a look at some of the pictures beta to understand this, okay, so here in beta, what is happening? There is a large stone inside the gallbladder. Suppose this is the large stone. Now this stone is putting pressure on the gallbladder wall, because of which the gallbladder wall is going to get eroded. Gradually what will happen? This stone is going to put pressure on the duodenal wall and the duodenal wall also gets eroded. If this happens beta, then an abnormal relation will develop between the gallbladder and the duodenum. If abnormal relation develops, suppose this is the gallbladder outline, then it will become somewhat like this. Now what can happen? This stone which is inside the gallbladder, this can slip into the duodenum. If it slips into the duodenum, you know what is going to happen. The stone will be traveling into the duodenum, jejunum, ileum, right? The duodenum, then jejunum, ileum and the terminal ileum. And here you know there is a ileocecal valve at the ileocecal junction. So this gallbladder stone may get arrested here. This gallbladder stone may get arrested here because of the ileocecal valve. Complete traffic jam situation beta. Again an emergency situation. Traffic jam in the intestine. Nothing will be able to move here. The proximal pupil will dilate. Patient will have severe pain all over the abdomen. Because of dilatation of the proximal intestinal loops, there will be distension of abdomen. Pressure in the proximal loops of intestine will be high. So there may be vomiting and nothing is passing down. So there is constipation. These are the cardinal features of intestinal obstruction beta. Pain, vomiting, distension, constipation. I repeat beta, pain, vomiting, distension, constipation. There is a traffic jam here, proximal pupil dilated, severe pain all over the abdomen, high pressure in the proximal part, vomiting, distended intestinal loops, distension of abdomen, nothing passing out here, constipation. So this is how these patients can present to us. Obviously, this is the emergency situation. If we take a X-ray in this emergency, we can find a regular striate. This is because of traffic jam in the small intestine. you will find multiple air fluid levels. If we try to recall pediatric surgery, beta, single bubble, pylorus, double duodenal, triple jejunal, multiple central small intestine, multiple peripheral large intestine. This is small intestine. So multiple air fluid levels in the central part of abdomen. This is one thing we see on X-ray. Second thing what we see, beta, normally we don't see air inside the gallbladder. But if there is an abnormal relation of gallbladder with the duodenum, you know your GIT right from mouth to anus is full of air. यहाँ से हवा पीते हैं और वहाँ से निकालते हैं. So if there is an abnormal relation of duodenum with the gallbladder, so the air in the duodenum will be going into the gallbladder. This air in the gallbladder can be seen on X-ray, right? So you see multiple air fluid levels, then air in the gallbladder. And sometimes if this stone is having calcium, rarely we can even see this stone on the X-ray. So three things if we see on X-ray is called as a triad. Multiple air fluid levels, air in the gallbladder, stone in the intestine. And in the treatment for these stones, gallstones obstructing the intestine, we open the abdomen, go inside. There is no need to open the intestine. Before opening the intestine, we try to crush the stone from outside only. Right? You are inside the abdomen. You have done a laparotomy. You go to the ileocecal region. Here you see there is an obstruction. Before you open the intestine, you can feel the stone in this area. So without opening the intestine, you can try to crush the stone. If you are able to crush the stone, then the stone fragments, you just milk this intestine like this so that the fragmented stones, they can pass into the cecum. If the fragmented stones pass into the cecum, there is no need to open the intestine. The traffic jam is cleared and then the entire story will be cleared. So we have to just remove the obstruction. Now let's see beta what all is written here. Most commonly, gallbladder fistula is seen with first part of duodenum. इसको क्या बोलेंगे बेटा अपन? Cholecysto is for gallbladder, duodenal for duodenum, and fistula for fistula. So it is a cholecystoduodenal fistula. Because of this, gallstones slip into the duodenum. It will travel into the intestine and it will get impacted in the terminal ileum, or you can write it as distal ileum. Intestinal obstruction. Intestinal obstruction due to gallstone. This is called as gallstone ileus. When we take the X-ray, we can see a regular stride, and this regular stride is multiple air fluid levels, air in the gallbladder, and stone in the intestine. And the treatment is simply removal of the obstruction. Right, beta? Now what we'll do is we'll take a break here and we'll be back at 5:35 p.m. Right? Thank you very much for your patience, beta. I hope you are able to understand the things. Right, beta. So we are back, and now let us take a look at the stone in the CBD. Just a moment. Right, beta. So now let's take a look at the stone coming into the CBD, and I hope we all can understand what is going to happen. Just a small story, beta, just to give you an idea that here what you are seeing is a complete obstruction, right? But sometimes the stone may be lying somewhat like this, and there may be just a partial obstruction. So if there is a partial obstruction, there will still be some space for the bile to flow from the side. Patient may not present to you in emergency. But if it is not lying like this, rather it is lying like this, that means it is a complete obstruction. The proximal pupil will dilate nicely. The patient will have jaundice, stasis of bile, bacterial party, acute inflammation, cholangitis, sudden onset of severe pain in the right hypochondrium radiating to the back, and high-grade fever with chills and rigors. Pain, fever, jaundice, pain, fever, jaundice, pain, fever, jaundice, Charcot's triad. And sometimes when this bacterial party starts going into the blood, septicemia, hypotension, and mental confusion. Okay, that is Raynaud's pentad. So let us see how we need to actually approach these situations of stones in the common bile duct. As we just now saw that this is the right hepatic, this is the left hepatic duct. This is the common hepatic duct. Now here lies the gallbladder. And then there is the cystic duct coming, then there is the common bile duct coming here. Now how these stones would be lying inside, if we just try to correlate with this situation. Thank you, beta. This is the right hepatic duct, this is the left hepatic duct, this is the common hepatic duct, this is the gallbladder, this is the cystic duct, and here this is the common bile duct, right? Now if I say, beta, that there is a stone which is causing a partial traffic jam situation, somewhat like this, versus a stone which is causing a complete traffic jam situation like this, the presentation of the patient would be different. Why we can find these stones inside the common bile duct? That is because of stones slipping from the gallbladder into the CBD, or may be associated with bile duct infection. One thing, I really thank you, beta, for reminding me that I missed out something somewhere, and that was in bariatric surgery. I forgot to mention what is the most effective bariatric surgery. So beta, please make a note here. The most effective bariatric, and thank you for reminding me, beta, that I missed it out. Most effective bariatric surgery is a Roux-en-Y gastric bypass. This is the most effective bariatric surgery. The video what we saw of bariatric surgery, that is Roux-en-Y gastric bypass. Right. So coming back to the stone in the common bile duct, beta, how the patient can present to us, depending on whether it is a partial or complete traffic jam. If there is a partial traffic jam, beta, we can understand that this is not going to cause progressive jaundice. This will be intermittent jaundice. Why intermittent, beta? Because what will happen due to a partial obstruction, sometimes the bile will find difficulty in flowing down. So this may lead to some jaundice. The proximal muscles will contract forcefully, and then they will try to throw all this bile through the side of the stone. If all the bile passes through the side of the stone into the duodenum, then the jaundice will disappear. Again, there is a possibility that there may be collection of bile here leading to some jaundice. Again, the proximal muscles contracting, and they will throw the bile down, right? Okay. If there is a partial traffic jam, there will be intermittent jaundice beta. And we all know any patient presenting to us with jaundice, the first investigation will always be liver function test. We can also do a ultrasound of the abdomen. For these CBD stones, what we can do is MRCP and ERCP. Ideally, MRCP is the investigation of choice, that is magnetic resonance cholangiopancreatography. But whenever any diagnostic or therapeutic procedures have to be done, we can do ERCP. In ERCP, what we do, beta? We pass a endoscope from the mouth, right? Suppose this is the esophagus, this is the stomach area, this is the duodenum area. Suppose I just expand the duodenum area a little bit. Suppose I say that this is the duodenum area. Now you are passing the endoscope from here, from the mouth. The endoscope is going down. You go here, and here lies the common bile duct. And what we are talking about just now is there is a stone inside the common bile duct. So what we can do is we can pass a Dormia basket type of instrument through the side channel. We'll pass a basket type of instrument. We'll take the basket end above the stone, press the button, open the basket. When the basket is opened, try to withdraw it. As soon as you are withdrawing this basket, the stone will be caught within the wires of the basket, and you just tighten the entire assembly and you can remove the endoscope out. That is how you can remove these CBD stones via ERCP. So whenever diagnostic or therapeutic procedures have to be done, we can go for ERCP. In the treatment for these CBD stones, beta, very simple. We are doing ERCP plus sphincterotomy. You know there is a sphincter of Oddi here. So we have to cut the fibers of the sphincter to facilitate the passage of stone. And then we do CBD stone extraction. CBD stone extraction with Dormia basket. With Dormia basket. This Dormia basket, beta, we were using in salivary glands also. When there was a stone in the submandibular duct, we were passing this endoscope and removing the stone with the Dormia. We will also be using this Dormia basket for removing stones from the ureter. Any tubular structure in the body, if there is a stone and if that area can be assessed by endoscopy, then we can remove these stones with the help of Dormia basket. I repeat this in Hindi, beta. हमारी बॉडी में जितने भी ट्यूबुलर स्ट्रक्चर्स हैं, ट्यूब जैसे स्ट्रक्चर हैं, उनमें अगर पत्थर है और अगर उन ट्यूब्स को एंडोस्कोप से एक्सेस किया जा सकता है, तो हम एंडोस्कोप डाल के, बास्केट डाल के वहां से पत्थर निकाल सकते हैं, राइट? ओके बेटा. Now another presentation here is in emergency. The patient is presenting with cholangitis, and you all know this Charcot steroid, that is pain, fever, jaundice. Very famous steroid, very commonly asked in our exams. And Raynaud's pentad, that is pain, fever, jaundice plus hypotension and mental confusion. Hypotension and mental confusion. So if the patient is presenting with septicemia type of features, again our duty as a doctor is to save the zindagi. Zindagi bachana हमारा सबसे पहला काम है. We start IV fluids and aggressive IV antibiotics. If possible, we can do a quick LFT and ultrasound of the abdomen, and we'll come to know that, boss, there is a complete traffic jam in the CBD. There is a bacterial party going on. Just have a look, beta, what would be happening here. There would be biliary stasis in this situation, complete traffic jam. So there would be a big stasis leading to bacterial party here. Because of this party, the entire CBD would have become acutely inflamed, and now there is septicemia type of story going on. So in order to save the life, beta, what we can do is just have a look here. If there is a party going on, then what we are supposed to do, we pass the endoscope into the CBD here, and then through the side channel of this, we pass a stent. Now the stent here is just like the refill of your pen, beta. If you are able to negotiate the stent through the side of the stone and take it into the CBD where party is going on, suppose there is a party going on in this area, so when you have passed the stent, all this party will come into the lumen of the stent. जैसे पेन की refill में lumen होती है ना बेटा, so when the bacteria is coming here, then the bacteria would be coming here. You just remove the endoscope. You just remove the endoscope, and here is lying the stent like this. So whatever bacterial party is going on, that is coming into the wires of the stent, and now all this bacterial party would be going down into the duodenum, jejunum, ileum, colon, rectum, anal canal, and out. So that is how you can save the life of this patient. In emergency cholangitis situation, beta, reason may be any. If there is a bacterial party going on in the CBD, we have to do a endobiliary stenting, ERCP and stenting. This is what is going to save the life, endobiliary stenting, which we can also call as ERCP and stenting. This is our image. What we are seeing here. Now in this particular image, beta, this what you are seeing, this is the endoscope which is coming from the stomach into the duodenum. Now in the second part of the duodenum, we have pushed the contrast into the common bile duct. When the contrast is flowing here, what will happen? Suppose I say, beta G, that this structure what you are seeing, this is the common bile duct. And suppose I say there are multiple stones in the common bile duct. Now, if there are multiple stones here in the common bile duct, will the contrast be going inside the stone? No, the contrast will be flowing through the side of the stone. So, you will not be able to see the contrast inside the stone. Rather, they will appear as filling defects. Contrast पत्थर के अंदर नहीं जा रहा ना बेटा, तो पत्थर के अंदर कॉन्ट्रास्ट नहीं दिख रहा, इसलिए पत्थर फिलिंग डिफेक्ट है, राइट? द स्टोन्स आर अपीयरिंग एज फिलिंग डिफेक्ट्स. कैंसर विल आल्सो अपीयर एज अ फिलिंग डिफेक्ट, राइट? चलिए जी. Another thing which I would like to remind you, beta, whenever you are writing any emergency situation, wherever we are writing any emergency situation, like in fistula of gallbladder, right? Patient was presenting with intestinal obstruction, and the treatment what we have written there is simply removal of obstruction. Actually speaking, just removal of obstruction is going to relieve the emergency situation. Once we have done this, and then when the patient becomes normal, we call this patient again after few months, and then we have to do the definitive treatment for this. We have to chop the fistula, repair the duodenum, remove the gallbladder. That is the definitive treatment for fistula of gallbladder, है ना? But that is something we are not doing in emergency. Emergency में patient की जिंदगी बचाना is more important. The same concept applies here, beta. We are doing this procedure just to save the life of the patient. Once the life is saved, then we'll call the patient again, and then we can do this procedure, and we can remove the stone from the CBD, right? Okay. Now, if we go back to this video, beta, If we try to see once again, now what we are trying to understand is if the stones further slips, what can happen? Now the stone is coming into the pancreatic duct. You can see there is a complete traffic jam. The pancreatic juice, which was supposed to go like this, stasis, bacterial party, acute pancreatitis. This is what can happen, right? Obviously, the commonest cause of acute pancreatitis is gallstone. The second cause is alcohol. What happens in these situations, beta? Because of a complete traffic jam, the pancreatic enzymes are not able to go there. So they are getting concentrated here itself. And this causes premature activation of the pancreatic enzymes within the pancreas. Normally, the pancreatic enzymes get activated when they come into the duodenum. But in these situations, they might get activated within the pancreas itself. And you know what is the job of pancreatic enzymes? Digestion. So if they get activated within the pancreas, they will start digestion of the pancreas. That means these enzymes will start causing necrosis of the pancreas itself, right? And this is what we call as necrotizing pancreatitis, right? Just imagine that in the retroperitoneum, the pancreas is getting necrosed. It is not only the pancreatic tissue which is getting necrosed, but maybe even there is erosion of the blood vessels inside the pancreas. Bleeding would be taking place. That is called as hemorrhagic pancreatitis, right? How these patients actually present to us. Whenever this pancreas gets acutely inflamed, then the patient presents with sudden onset of severe pain in the central upper abdomen. And then this pain radiates to the back, either from the right side or from the left side, and it goes here. Now just imagine there is a red hot pancreas in this area. What will happen? The patient is having nausea, anorexia type of thing. If you ask this patient to lie down supine, the weight of the abdomen will be falling into the red hot pancreas, and the patient will feel lot of pain. So these patients, they cannot lie down supine. They always want that please allow them to sit, and when they are sitting, they are leaning forwards so that there is no weight on the retroperitoneum. This type of presentation on 17th of December, beta, sudden onset of central upper abdominal pain, radiating to the back, not able to lie supine, but feels relief on sitting and bending forwards. This is classical presentation of acute pancreatitis, right? Apart from this, in these patients, what we have seen, when there is necrosis of the pancreas going on, if there is bleeding going on, then this blood will trickle down and may come to lie anteriorly, which may give bluish discoloration. Bluish discoloration in the flank area is Gray Turner sign. Bluish discoloration around the umbilicus is Cullen's sign. So Gray Turner and Cullen's sign, they can be seen in acute hemorrhagic pancreatitis. Also, I would like to tell you, beta, whenever there is an enzymatic party going on in the pancreas, remember this is an enzymatic party, not bacterial party. Whenever this enzymatic party is going on, the peritoneum wants to secrete lots and 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 lots of fluid in order to neutralize these enzymes. So there is huge amount of fluid sequestration in the retroperitoneum. जब ये एंजाइम्स की पार्टी चल रही है ना बेटा रेट्रोपेरिटोनियम में, तो जो पेरिटोनियम है वो बोलते कि भैया ये क्या हो रहा है, वो खूब सारा पानी सेक्रीट करना शुरू कर देती है जिससे कि इन एंजाइम्स को न्यूट्रलाइज किया जा सके. There is so much of fluid loss that patient goes into a state of shock, and in shock we know patient would be presenting with tachycardia, hypotension. So these can be the features in a patient presenting with shock of acute pancreatitis. Now, obviously, what we are supposed to do if the patient has come to you in February 23 in a state of shock, the first thing is we have to manage the shock. We have to save the life of this patient. So pumping in IV fluids is going to be the most crucial in saving the life of acute pancreatitis patient presenting with shock. You start pumping in IV fluids. If the intravascular volume increases, the patient would be settling down. Now, you do your clinical examination. You may find some tenderness in the upper abdomen. You can get the pancreatic enzymes tested, like serum amylase and lipase. Amylase, it starts rising immediately in acute pancreatitis, and it remains elevated for 3 days. But the problem with amylase is that it is non-specific. विश्वास नहीं कर सकते इस पे. We cannot rely on amylase, because amylase can rise in other acute inflammatory conditions also. It can even rise in acute cholecystitis. So, we cannot rely on amylase, but unfortunately there is nobody else which can give us some idea. If the value of amylase is found to be more than 3 times the normal value, then it favors acute pancreatitis. Another enzyme is lipase. That is specific. That rises in pancreatitis only. But the problem with lipase is it starts rising after 3 days of acute pancreatitis. So first 3 days we rely only on amylase. After 3 days we start relying on lipase. If suppose we take a X-ray in acute pancreatitis, we can find some signs like colon cutoff sign, sentinel loop sign, and a renal halo sign. If there is any doubt about acute pancreatitis, then we do a CT scan. That is the radiological investigation of choice in acute pancreatitis, right? But all this is done once the shock has been managed. Okay, now shock has been managed, amylase, lipase done. Suppose the diagnosis of acute pancreatitis made. Now what? Now we have to treat this. Should we give antibiotics in this or not? No, this is the enzymatic party. It is not a bacterial party. Acute pancreatitis initially, it is enzymatic party. So there is no role of antibiotics initially. But yes, if suppose necrosis is taking place in the pancreas, अगर pancreas में necrosis हो रही है, अगर pancreas सड़ रहा है, मर रहा है, then this dead tissue, definitely the bacteria will infect this dead tissue, and secondary infection can occur in pancreatitis. If secondary bacterial infection has occurred in pancreatitis, then yes, we have to give antibiotics. Otherwise, no. Ultimately, what we are supposed to do for this, the culprit is this. We have managed the shock, everything is stable. Now what we can do is, we have to remove this stone. And beta, I am 100% sure that all of you know how you will take out this stone. Perfect. Let's have a big round of applause for all of you. You will pass the same endoscope here. You will pass the Dormier basket here. First, you will divide the sphincter so that you can remove the stone easily. So, endoscopy, sphincterotomy, stone extraction with a Dormier basket. If you are able to clear the traffic jam, all this story will start flowing into the duodenum nicely, right? And everything will settle down. That is how we treat this acute pancreatitis. Right, now let's see what all is written here. Acute pancreatitis. It is simply acute inflammation of the pancreas. Patient present with sudden severe abdominal pain, shock, and raised levels of pancreatic enzymes. This is just a pictorial representation, beta, just to demonstrate that if suppose I say this is the pancreas. If this is the pancreas, And suppose this is the pancreatic duct. Above suppose is the common bile duct. This is the right left hepatic duct, this is common hepatic duct, cystic, and the gallbladder story. Now we are talking about a stone which is blocking the mouth of the pancreatic duct here. Right? Because of which the enzymes are not able to flow into the duodenum. Proximal people are getting dilated. Stasis, pancreatic enzymes, they become active. They start causing necrosis of the pancreas. Right? Most common cause for acute pancreatitis, it is gallstone. However, second most common cause for acute pancreatitis is alcohol. In children, hereditary. बच्चों में gallstone होते नहीं usually, और बच्चे पीते नहीं. बच्चे खेलते कूदते रहते हैं. Children keep on playing. So trauma can cause acute pancreatitis. Operative cause of acute pancreatitis is ERCP. Sometimes ERCP can cause acute pancreatitis, and the simple understanding here is, suppose beta this here is the duodenum, right? And suppose you have passed the endoscope, and through the endoscope, suppose you have damaged the sphincter of Oddi. Here you know is the sphincter of Oddi. And if this sphincter of Oddi has been damaged, then what will happen? There will be reflux of duodenal contents into the pancreatic duct. This is the situation. We are not talking related to stone. We are just talking ki bhaiya, you have done a ERCP, you have done a sphincterotomy. So there will be reflux of duodenal contents into the pancreatic duct. This may cause acute pancreatitis, and this may cause cholangitis. So these will be called as reflux pancreatitis and reflux cholangitis. So operative cause of acute pancreatitis is ERCP. Basically what is happening here is a premature activation of the pancreatic enzymes within the pancreas, which causes necrosis of the pancreas. Patient presents with sudden severe upper abdominal pain radiating to the back, maybe from right or left side, which is relieved on sitting with bending forwards. This is the classical description what you get on 17th of December for acute pancreatitis. It is aggravated in supine position. Aggravated in supine position. Patient can present with nausea, vomiting. Fever is generally not a feature in acute pancreatitis. Fever is due to secondary bacterial infection. Because of huge amount of fluid secretion, we may find fluid collection in the abdomen, ascites. Not only the peritoneum, but even the pleura may react to this inflammation. And this pleura can also secrete lots and lots of fluid. So there may be pleural effusion. Because of necrosis of the vessels in the pancreas, there may be bleeding in the retroperitoneum, which is a feature of acute hemorrhagic pancreatitis. Because of this, we may find bluish discoloration. If you find this bluish discoloration in the flanks, that is Gray Turner. If you find this bluish discoloration around the umbilicus, this is Cullen's sign. And this is something which is very commonly asked in our exams. Once I remember, 3 years back or 2.5 years back, they gave a picture where there was a pinky shadow around the umbilicus. And there was a story cooked somewhat relating to pancreatitis. And they asked, what is this? Answer was Cullen's sign. So, bleeding in pancreatitis and hemorrhagic pancreatitis, if the blood trickles and comes anteriorly, right, it may get collected in the flank area. This is Gray Turner sign. If it gets collected around the umbilicus, suppose here this is the umbilicus. So this what you are seeing, this is the Cullen's sign. If there is huge amount of fluid sequestration, the patient will land up in shock and patient will develop those signs of shock, tachycardia, tachypnea and hypotension. What we have to do is we have to save the life. If the patient has come to us in shock, IV fluids, intravenous fluids, this is what is going to save the life. No antibiotics required in acute pancreatitis unless there is secondary bacterial infection, right? What we are doing now, we are leaving this point here. Once the patient has been stabilized, then we can get the pancreatic enzymes done. In pancreatic enzymes, we have got amylase and lipase. Amylase starts rising immediately. It remains elevated up to 3 days. It remains high up to 3 days, but it is non-specific. However, if the value of serum amylase is found to be more than 3 times the normal, then it favors acute pancreatitis. More than 3 times the normal value favors acute pancreatitis. Serum lipase is specific. We can rely on this serum lipase. If suppose we are doing X-ray in acute pancreatitis, however, nowadays, beta, we are not doing these X-rays, but want to mention, we can find a colon cutoff sign. We can find a sentinel loop sign. We can find a renal halo sign. Let us just try to understand beta how we can find these signs. On X-ray, air appears black, fluid appears white. Now, if suppose there is a acute inflammation of the pancreas in the retroperitoneum, so this pancreas has become red hot, and because of this edema and everything, this might be putting pressure on the colon anteriorly. When you are taking the X-ray beta, you can see the gas in the colon. So there is a right colon on this side, you might be able to see the gas here, and then here there is a transverse colon, and here there is a descending colon, right? So on X-ray, you may find gas in this, but because of inflamed pancreas, this might be pushing the transverse colon. So the gas from the transverse colon moves either to the right or to the left or on both the sides. मतलब अगर ये लाल गुस्से से pancreas transverse colon को दबा रहा है, तो जो transverse colon में हवा है ना, वो दाएं बाएं move कर जाती है. So when you are taking the X-ray, you don't see air in the transverse colon. You might be seeing air in the right colon, you might be seeing air in the left colon, but you are not seeing the transverse colon air here. That is what we call as colon cutoff sign. Colon cutoff sign. That can also be called as Akela Anath sentinel loop sign. And sometimes in acute pancreatitis, what happens when there is fluid collection in the retroperitoneum, then this fluid collection in the retroperitoneum may create a shadow around the kidney. Suppose I say beta that here lies the kidney. Then because of huge amount of fluid collection around the pancreas, we may find this fluid collection around the kidney. And we know that fluid appears white on X-ray. So we may find white story around the kidney. This is called as a renal halo sign. जैसे भगवान जी के चारों तरफ वो एक हेलो जैसा दिखाई देता है ना, just like you see some shadow around God's head, right? So that is a halo sign. There is a halo around the kidney. That is a renal halo sign. Right, beta. If we are in doubt, then we do a CT scan. This is the radiological investigation of choice. Surgery is generally not required in the treatment of acute pancreatitis. Once the diagnosis is made, then we do ERCP. ऊपर आ जाओ बेटा. Then we do ERCP, sphincterotomy, and stone extraction with Dormia basket. Stone extraction with Dormia basket. है ना? So once you remove the traffic jam, once you remove the stone, then the story will settle. Right, beta. Surgery is generally not required in the treatment for acute pancreatitis, but there might be some specific indications for surgery. For example, if suppose there is secondary bacterial infection and abscess forms around the pancreas. So we know the concept, beta. If there is any collection of pus, we have to drain it. If the pus collection is localized inside the body, we'll make an incision on the skin. Under ultrasound guidance, we'll pass a catheter into the abscess cavity. Just like what we were doing a tube cholecystostomy for gallbladder, beta, we can do the same story here. We can just put a tube and drain this abscess outside. So this is called as percutaneous drainage. Percutaneous drainage under ultrasound or CT guidance. Percutaneous drainage under ultrasound or CT guidance. Another indication of surgery, beta, if there is necrosis taking place in the pancreas. If it is not infected, no treatment. But if the necrosis gets infected, then we have to remove that infected dead tissue. Removal of dead tissue from the body is called as debridement, or removal of necrotic tissue will be called as necrosectomy. So removal of the infected necrotic tissue is called as pancreatic debridement or pancreatic necrosectomy. Sometimes beta pseudocyst can develop around the pancreas. Now what this pseudocyst is all about? Let us, very simple to understand, beta. This is the head of the pancreas. This is the body. And here is the tail of the pancreas, right? We are talking about ki bhaiya, there is a traffic jam in the pancreatic duct. Suppose there is a stone which is causing a traffic jam here. We can understand that this pancreatic duct, proximal pancreatic duct, is getting dilated. Pressure in this duct is increasing. So when pressure in the duct is increasing, there is a possibility that this duct may rupture. And suppose this ruptures, there will be leakage of pancreatic enzymes. These pancreatic enzymes, suppose I use a green color. These are the pancreatic enzymes which were collected inside. Now they leak out. and they leak around the pancreas. We know that peritoneum is secreting lots and lots and lots and lots of fluid. So there is fluid collection also which is taking place around the pancreas. And in this fluid collection, we may find these pancreatic enzymes as well. This generally what happens, beta, once you have stabilized the patient, and if you are able to remove this traffic jam through ERCP, अगर अपन ने इस पत्थर को निकाल दिया, रास्ता खुल गया, as soon as the traffic jam is cleared, whatever collection is taking place here, that collection will come back into the duct and that collection will pass into the duodenum and this will disappear. This is what happens usually. But sometimes, beta, if by chance this is not able to come down, this collection will keep on increasing, and because of increasing collection, it can form a cyst. It is actually simply collection of fluid and enzymes. इसमें क्या है बेटा? Basically पानी है and enzymes हैं, है ना? Sorry, fluid and enzymes, है ना? So this what you are seeing, this is just fluid and enzymes. There is no lining here, there is no epithelium around. It is simply collection of fluid and enzymes, and that is why we call it as pseudo. There is no lining, इसकी अपनी कोई lining नहीं है, इसलिए इसको बोलते हैं pseudocyst, right? Usually these cysts are small, patient is asymptomatic, and they resolve spontaneously. But sometimes they may become large. If they become large, they can become very large. They may extend from mediastinum above to the pelvis below, and they may put pressure on these structures like stomach. Patient can have epigastric pain. Another thing, beta, if the enzymes are going into the cyst, that means enzymes are not coming into the duodenum, but dosa idli is coming into the duodenum. So dosa idli, just imagine, dosa here, dosa in the stomach, dosa in the duodenum, no enzymes, dosa in the jejunum, no digestion, dosa in the ileum, dosa in the colon, dosa in the stool, dosa, 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 dosa stool. Right? This is just to give you an idea. Beta, if the enzymes are not coming into the duodenum, the food is not getting digested, right? This is going to create severe malabsorption issues. Sometimes this cyst can become infected, it can rupture. Malignancy will never be a complication in pseudocyst. Because malignancy के लिए, for malignancy there has to be some lining, some epithelium from where the cancer can grow. Pseudocyst does not have any lining, so there is no chance of cancer in pseudocyst. Abhi, obviously if the cyst is too large, if the patient is having symptoms, if there are complications, then we need to treat these pseudocysts. Abhi, what treatment should be done for these pseudocysts, beta? This is having enzymes. Enzymes are supposed to go in the duodenum, right? So what should be done? Should we simply do a aspiration? Acha, if we simply do a aspiration, suppose I say, beta, that we put a catheter into the cyst, right? A catheter into the cyst, ultrasound guided, and drain the cyst outside, right? That means the pancreatic enzymes are drained outside, the fluid are drained outside. You can collect this enzyme in a glass, right? Collect these enzymes in a glass. And now whenever patient wants to eat dosa, patient is eating dosa, pancreatic enzymes in the glass, dosa, pancreatic enzyme. Now the dosa can be digested. But But we cannot do this, right? We cannot just put a catheter into this pseudocyst, drain the pancreatic enzymes outside, collect them in a bag, and then whenever patient wants to have a meal, we can give these pancreatic enzymes along with the meal. It is better, rather than doing a external drainage, don't do this. It's better that you do a internal drainage. That means you just communicate the cyst with intestine inside. That means we have to have something in the intestine, and we know there is one innocent guy in GIT. So we bring the jejunum and connect the cyst with the jejunum. So all the enzymes will start coming into the jejunum. Dosa, mouth, esophagus, stomach, duodenum, jejunum, enzymes, jejunum, dosa, enzymes, dosa, digested. No dosa outside, right? So we can do a cystojejunostomy, or we can do a cystogastrostomy, or we can do a cystoduodenostomy depending on the location of these cysts. So just wanted to tell you the concept of these pseudocysts beta. These are the images how these cysts may look like. CT scan image. This what you're seeing beta, this is the liver. This what you're seeing is the spleen. And here what you're seeing, this is the pseudocyst. This is the pseudocyst what you're seeing here, right? This is the pancreas what you're seeing here. Right. So this is how pseudocyst can look like. Another picture, again a CT picture. Here this what you're seeing is the liver. This shadow what you're seeing is the stomach, and this what you're seeing is the cyst. This is the pseudocyst. So pseudocyst is simply collection of pancreatic enzymes and fluid around the pancreas. Usually they are small. Patients are asymptomatic and they resolve spontaneously. We don't need to do anything. Important beta, they are called pseudo because it is not lined by epithelium. It is not lined by epithelium. That is why we call it as pseudo. Sometimes they can become large. If they become large, they can become very large. They can extend from mediastinum above to pelvis below. Patient can present with pressure symptoms like epigastric pain, malabsorption. These can be the various symptoms. Complications which can occur: abscess, rupture. But malignancy, never in pseudocyst. Malignancy कभी नहीं होगी because there is no epithelium. Malignancy will never occur in a pseudocyst because there is no epithelium. Investigation of choice would be a CT scan. लिख लिया बेटा? Okay. If patient is asymptomatic, no treatment. But if patient is symptomatic, or complications or more than 12 weeks duration, Then we do internal drainage. Internal drainage means we just connect the cyst with intestine. That is cystoenterostomy. For doing this, we prefer doing a cystojejunostomy. If the cyst is lying close to the stomach, we can even do cystogastrostomy. If the cyst is lying close to the stomach, we can do a cystogastrostomy. So beta CJ is cystojejunostomy. CG is cystogastrostomy. Both cystojejunostomy, gastrostomy can be classified as cystoenterostomy, right? We can even do a cystoduodenostomy if the cyst is lying very close to the duodenum. Various prognostic scores have been used in pancreatitis like Apache 2, Ranson, Glasgow, and SOFA score. Mortality rates in pancreatitis, if it is just a mild acute pancreatitis, then the mortality is less than 1%. But if it is severe or necrotizing pancreatitis, then the mortality is somewhere between 20 to 50%. That means severe necrotizing pancreatitis should not be taken lightly. Okay? Fine, beta. So this was a story related to acute pancreatitis. Now, if we look at the chronic pancreatitis, तो chronic pancreatitis में एक बार acute pancreatitis quickly rewind कर लेते हैं, right from choledocholithiasis. If we just try to recap that, what is actually happening there. क्योंकि gallbladder तो I'm pretty sure that you have got it nicely inside. Acute pancreatitis also, let us just try to move out from the gallbladder and let us just try to focus on that video. You can close your eyes, beta, where we saw in the video that how the stone from the gallbladder comes out through the cystic duct into the common bile duct. If the stone is in the common bile duct, we call it as choledocholithiasis. If the stone is causing only partial traffic jam, the patient will present in OPD with intermittent jaundice. We can do a LFT and ultrasound, and then we do a MRCP. Since we have to remove the stone, that means a therapeutic procedure has to be done. We do a ERCP, and through ERCP, we do a sphincterotomy and then do a CBD stone extraction with a Dormia basket. That is how we can remove the CBD stones from the mouth. Sometimes, if there is a stone in the CBD which is causing complete traffic jam, so the proximal pupil are dilated and there is a stasis in the proximal part, E. coli. So this is the bacterial party time, and this party causes acute inflammation of the proximal CBD, cholangitis, sudden onset of pain in the right hypochondrium, high-grade fever with chills and rigors, jaundice, pain, fever, jaundice as Charcot triad. This bacterial party can go into the blood, septicemia can occur, hypotension, mental confusion. This is the emergency situation where the patient is dying because of septicemia. So, we have to save the life first. Basic resuscitation, IV antibiotics, IV fluids, if possible, quick LFT and ultrasound, and then you have to remove the septic load from the bile duct. To remove the septic load or remove the bacterial party from the proximal bile duct, you do a ERCP and put a stent into the CBD. That is endobiliary stenting or ERCP and stenting. Once this is done, patient's life is saved. Let the patient be on antibiotics for few days. You can call this patient again after few weeks, and then you can remove the CBD stone with the help of endoscope and Dormia basket. This is the story of CBD stone. Now we come to the stone coming and blocking the pancreatic duct. Complete traffic jam in the pancreatic duct, proximal pancreatic duct getting dilated, stasis of pancreatic enzymes, premature activation of pancreatic enzymes in the pancreas. This causes necrosis of the pancreas. Not only necrosis of the pancreas, but also necrosis of the blood vessel, hemorrhagic pancreatitis, necrotizing pancreatitis, hemorrhagic pancreatitis. In this condition, the peritoneum reacts to this situation and there is huge amount of fluid sequestration in the retroperitoneum to neutralize the pancreatic enzymes. So much of fluid is secreted that patient lands up in shock. How these patients present to us: sudden onset of severe upper abdominal pain radiating to the back either from the right or the left, aggravated on lying down but relieved on sitting and bending forwards. Anorexia, nausea, vomiting. Fever is not a feature in acute pancreatitis initially because in acute pancreatitis it is not a bacterial party but it is a enzymatic party. However, patient may present to us with bleeding, bluish discoloration in the flanks, gray Turner, bluish discoloration in the around the umbilicus, Cullen sign. These are seen in acute hemorrhagic pancreatitis. Sometimes because of huge amount of fluid loss, patient is landing in shock-like condition, tachycardia, tachypnea, hypotension type of story, ascites, pleural effusion type of story is there. In the management, first we have to save the life of the patient, that is manage the shock, pump in IV fluids, that will save the life initially. Antibiotics are not usually required initially unless and until there is secondary bacterial infection. Now, if you are thinking about acute pancreatitis, you can get the pancreatic enzymes done, amylase, lipase. After making the patient stable, amylase starts rising immediately, remains elevated for 3 days, but it is non-specific. However, more than 3 times the normal favors acute pancreatitis. Lipase starts rising after 3 days, remains elevated for 12 days. This is specific. So after 3 days, we can rely on lipase. If we are taking X-ray in acute pancreatitis, we can see a colon cutoff sign, sentinel loop sign, and a renal halo sign. If there is any doubt, we can do a CT scan, which is a radiological investigation of choice. Once the diagnosis of acute pancreatitis is made and there's a traffic jam of the pancreatic duct by the stone, you can do ERCP, sphincterotomy, and the stone extraction with a Dormia basket, and the story will settle. Surgery is not required in the treatment of acute pancreatitis. Specific indications for surgery: if there is abscess around the pancreas, percutaneous drainage under ultrasound CT guidance, necrosis in the pancreas, sterile, nothing, infected necrosis, do a pancreatic debridement or pancreatic necrosectomy. Pseudocyst around the pancreas is simply collection of fluid and enzymes around the pancreas. This is not lined by true epithelium, so called as pseudocyst. Usually they are small, patient is asymptomatic, they resolve spontaneously. But sometimes they can become large, can become very large, mediastinum to pelvis, pressure, epigastric pain, malabsorption because enzymes are not going into the intestine, abscess, rupture can occur. Malignancy will never be a complication in pseudocyst because there is no epithelium. Investigation of choice would be a CT scan. And in the treatment, if the patient is asymptomatic, nothing has to be done. If the patient is having symptoms or complication of the cyst is present for more than 12 weeks, we do an internal drainage of the cyst with the intestine, cystoenterostomy, which is most often cystojejnostomy. We can also go for cystogastrostomy and cystoduodenostomy. Oh yeah. Did we miss out something? Very fast. Okay. Yeah, the common causes. Most common cause, the gallstone. Right, beta. Now let's talk something about chronic pancreatitis. अभी chronic pancreatitis में let us try to use the concept of ductectasia in the breast and stones in the salivary glands. Smokers and alcoholics, beta, they tend to lose water, they remain dehydrated. जो लोग सिगरेट पीते हैं, अल्कोहल लेते हैं, उनमें पानी की कमी होती है. So the different secretions of the body, they lose water. So secretions tend to become thicker and thicker. Now a chronic pancreatitis patient also, most common cause is alcohol. When we take the history from these patients, generally these are males after 40-45 years of age. When we take the history, we come to know that, oh my God, for the last 10-15 years, there's not even a single day when they have not taken alcohol. जब हिस्ट्री लेते पता चलता है कि भैया पिछले 10-15 साल से कोई एक दिन ऐसा नहीं गया जिस दिन पीना हो. अब बिकॉज ऑफ दिस अल्कोहल, the secretions are becoming thicker and thicker. So when thick secretions are traveling in the pancreatic duct, what can happen? Suppose this is the normal pancreatic duct, right? If I say that secretions of the pancreatic gland have become thicker and thicker, so these thick secretions may start causing some partial traffic jam situation at multiple places in the pancreatic duct. Abhi, if remember beta, this is not a complete traffic jam. This is simply that thick secretion which is traveling. It is not a stone which is completely blocking, right? So these thick secretions, they create a partial traffic jam type of situation. And if this type of situation persists for 10, 15, 20 years, then gradually what is happening? We can understand that there will be multiple dilatations and strictures in the pancreatic duct. Actually, the pancreatic duct would appear somewhat like this. There might be dilatations in the pancreatic duct, and there might be strictures in the pancreatic duct. So something like this. And this is because the thick secretions are creating some partial traffic jam situations. That is why the proximal duct is getting dilated. So multiple narrowing strictures and dilatations in the pancreatic duct. Abhi kya hoga beta? Because of this partial traffic jam, what will happen? There will be back pressure. है ना, बैक प्रेशर आएगा, and this back pressure will be coming on to the pancreatic cells. अच्छा बेटा, pancreatic cells में there are exocrine as well as endocrine. Suppose I say that these blue color, they are the exocrine cells of the pancreas, right, all over the place. And suppose I say the white color, they are the endocrine cells. We all understand beta that the job of exocrine, the blue color, is to produce the enzymes, right? Ab dhyan se dekhte beta. What is happening here? The enzymes ideally are supposed to come here like this. There are small ducts. But what is happening? Because of this back pressure, as the enzymes are not able to travel nicely because there are partial traffic jam situations, so there is a back pressure on these cells, exocrine cells and endocrine cells. This may cause damage to the exocrine as well as endocrine. If exocrine is getting damaged, they will not be able to produce the enzymes. So enzymes are already not coming in the intestine nicely. If there is further atrophy of the exocrine glands, the enzymes are not getting produced. So how will the dosa which is coming in the intestine, how the dosa will be digested if there are no enzymes? So the patient will have malabsorption. Apart from this beta, because of the back pressure, if the endocrine cells are getting destroyed, endocrine cells, islet cells, alpha, beta, delta. Alpha secrete glucagon, beta insulin, delta somatostatin. So when they are getting destroyed, majority 75% are beta cells. So major brunt borne by the beta cells. That means they will not be able to produce insulin. If there is deficiency of insulin, then how will the glucose get deposited from the blood into different cells of the body? So glucose in the blood will not be deposited in the cells. That means glucose level in the blood will be high. High glucose in the blood, diabetes. That is how we can correlate that why diabetes occurs in chronic alcoholics. जो लोग chronic पीते हैं उनमें डायबिटीज क्यों होती है? Because of destruction of the endocrine cells. When we have to manage these patients, on the history we can come to know कि हाँ भैया there might be chronic pancreatitis. We can do ERCP, MRCP. If we are doing MRCP, we can see multiple dilatations and strictures. That is called as chain of Lake's appearance. In the treatment, if the patient is presenting with malabsorption, then we give pancreatic enzyme tablets. If you go to the chemist shop, na beta, then chemist shop is having pancreatic enzyme tablets. So whenever patient wants to have dosa, ask the patient to take that pancreatic enzyme tablet along with the dosa, or you can mix that pancreatic enzyme tablet within the masala of the dosa, right? So that the enzymes are also going simultaneously. Also, for diabetes, we give insulin. Another thing what these patients experience is pain. Whenever the patient takes the dosa, whatever exocrine cells are working, they will secrete the pancreatic enzyme. And when this pancreatic enzyme comes in the duct, because there is a partial traffic jam, there is a congestion in the duct, which causes pain in the epigastric region. This pain is aggravated after meals, right? Salivary stones, mealtime syndrome. Whenever the patient eats, if there is a traffic jam in the duct, like stone in the submandibular duct, the saliva is secreted, but the saliva cannot flow into the mouth. So all this congestion is there in the gland, and there is pain and swelling at the angle of mandible at meal times, mealtime syndrome. Same concept here, beta. When the patient takes the dosa, because the enzymes which are coming into the duct, they are not freely able to flow into the duodenum. Congestion in the pancreas, pain in the upper abdomen, aggravated on meals. It is because of this reason we tell these patients कि भैया don't take a bulky meal, otherwise you will have lot of pain. You can take small frequent meals. Divide one dosa into 6 parts, and then you can have that 1/6 dosa in the morning 8 o'clock, 1/6 dosa at 11 o'clock, 1/6 dosa at 2 o'clock, and so on. So small frequent meals is what we can do. Sometimes if the patient is having severe pain, then we have to drain these pancreatic enzymes. If we are not able to drain the pancreatic enzymes into the duodenum because of multiple strictures here, then we request the innocent guy. वही शरीफ आदमी को याद करते हैं बेटा. And now we tell the शरीफ आदमी, look my dear friend, the jejunum just lie over this pancreatic duct. And you know there are dilatations in the pancreatic duct. So you just make a cut corresponding to dilatations in the pancreatic duct and join the dilatations of the pancreatic duct with the jejunum. Side of the pancreatic duct to the side of the jejunum. Side of the pancreatic duct to the side of jejunum. You are creating multiple holes here. Right? So side of the pancreatic duct with the side of the jejunum. What will happen? Whatever dilatations are there, if you connect those dilatations with the jejunum, the secretions will come into the jejunum. The enzymes will come into the jejunum. This is called as side to side. Side to side. This is called as side to side. See. These are the dilatations in the pancreatic duct, and now you have put the jejunum over it and connected. So this is a side-to-side pancreaticojejunostomy, or a longitudinal pancreaticojejunostomy, or a modified Pusto's operation. That is what we do in the management of pain in chronic pancreatitis. Right, beta. Let's take a look. Most common cause. Most common cause of chronic pancreatitis is alcohol. Second most common cause is gallstone. Chronic pancreatitis is a irreversible condition where there is pancreatic cell atrophy. There may be calcifications, stricture and ectasia. Ectasia means dilatation. Duct ectasia was lactiferous duct dilatation. Stricture and ectasia of pancreatic duct. This is 4 times more common in males, and this is usually seen after 40 years of age. Patient can present with 3 stories: pain, malabsorption, and diabetes. Pain in the epigastrium, which is aggravated after meals. Malabsorption because pancreatic enzymes are either not produced or they are not coming into the duodenum. And diabetes, as insulin is not getting produced. When we do ERCP, MRCP beta, we get a chain of lakes appearance. Chain of lakes appearance. Chain of lakes appearance on MRCP or ERCP. In the treatment for malabsorption, we give pancreatic enzyme supplements which are available at the chemist shop. सच्ची में available होते हैं बेटा. They can be synthesized. Pancreatic enzyme supplements. In the market, there are tablets like Pancreatoflat, Creon. These are the name of the tablets of pancreatic enzymes. For diabetes, we are giving insulin. For pain, most important advice, इसको छोड़ दो, लेकिन मानता नहीं. Small frequent meals. We can use drugs like octreotide, which can help in reducing the congestion in the pancreas. And surgical treatment for chronic pancreatitis is longitudinal or side-to-side pancreaticojejunostomy. Longitudinal or side-to-side pancreaticojejunostomy. The blue color what you're seeing beta here, these are the dilatations in the pancreatic duct. We are just making our incision corresponding to dilatations in the pancreatic duct, and then we are making incisions on the side wall of the jejunum also and at these areas. This is what we are calling side-to-side pancreaticojejunostomy. This is also referred to as Fraze operation. Right? So in the right hypochondrium, we talked about the stones inside the gallbladder, why they form, cholesterol pigment mixed, how the patients can present, more than 80% asymptomatic. Symptomatic OPD, symptomatic emergency. What should be done in asymptomatic? No treatment except those 10 conditions where we have to do a cholecystectomy even if asymptomatic. Symptomatic OPD, ultrasound, lap chole. Symptomatic emergency, acute cholecystitis, red hot gallbladder, Murphy's sign, IV fluids, IV antibiotics, stabilize the patient. Once the infection settles, discharge the patient from the hospital after 5 to 7 days, call the patient back again for interval cholecystectomy. Then we talked about the different conditions of gallbladder, mucocele, empyema of gallbladder, then strawberry gallbladder cholesterosis, porcelain gallbladder, then Mersey's syndrome, fistula of gallbladder, and then we discussed choledocholithiasis, acute pancreatitis, chronic pancreatitis. So this was whole story related to bile and pancreas thing. Now in the right hypochondrium, we also find liver abscesses sometimes. These liver abscesses may be single or may be multiple. Even a hydrated cyst may be found inside the liver. So we are just classifying them into pyogenic liver abscess. Pyo means pus. Pus means bacteria. So pyogenic liver abscess will be related to bacteria. Amoebic. Amoebic is by that protozoant amoeba histolytica, right? गोलगप्पे खाते हैं ना जब हम पानी पूरी, so that golgappe wala, if he is not using that glove and he is just churning that pani in that, and you enjoy when he is dipping his bare hands into that pani and then you are eating that. So there are a lot of ant amoeba moving in that, right? Okay. So that can cause these amoebic liver abscesses. Sometimes hydrated cyst due to ingestion of that contaminated food by the Echinococcus granulosus, that can be seen inside the liver. So pyogenic means the story of bacteria. Streptococcus milleri, E. coli. These are the common culprits. Streptococcus milleri and E. coli. They can be single or multiple. Because it is a bacterial party, there is high-grade fever, chills and rigors. Because of damage to the liver, what you are seeing in the abscess, there is mixing of bile in blood inside the liver. So the patient will have jaundice as well. And definitely, because it's a bacterial party going on, there is a high risk of septicemia. Initially, what we can do, depending on how the patient is presenting, if the patient present with jaundice, then first we'll do LFT. If the patient presents with high-grade fever, chills, rigors and pain, then we go ahead with ultrasound of the abdomen. Best investigation here would be CECT. On CECT, we would be able to see these liver abscesses. We can do blood culture and pus culture to identify which bacteria is the culprit. And since it is a bacterial party beta, then we have to give aggressive antibiotics, gram positive, gram negative and anaerobes. तो इन तीनों को टारगेट करने के लिए बेटा what we can give is cephalosporins, penicillin group plus aminoglycosides plus metronidazole. If you give these aggressive antibiotics, then this bacterial party inside the liver can be controlled. But sometimes, even after giving these antibiotics, if the party is increasing and the septic load is increasing, there is an abscess inside the liver, again a localized collection of pus inside the liver. So we follow the same protocol beta. We can do a ultrasound guided percutaneous catheter drainage. The same story. Like if you take a look at this picture beta, this is a CT scan which is showing a abscess inside the liver. There is a bacterial party going on, suppose. Okay, though it is an amoebic liver abscess, but if there is a bacterial party going on here, then you can just put a drain into this abscess cavity under ultrasound or CT guidance. And that is how you can remove the septic load. But generally we try to treat them with heavy antibiotics. Now if we take a look at the amoebic liver abscesses beta? Amoebic liver abscesses are caused by Entamoeba histolytica. है ना, प्रोटोजोआ है ये, Entamoeba histolytica. Usually they are single. Patient can present with fever, jaundice. When the patient ingests that Entamoeba, na, so that amoeba is going into the intestine. So in intestine also it can create something. It can create ulcers. The ulcers in the intestine with amoeba, they are flask-shaped ulcers, and they are seen in sigmoid colon and the cecum. Right? You can just imagine, beta, the sigmoid colon and cecum may be the habitat areas for this amoeba. Now cecum is the midgut and sigmoid colon is the hindgut. If you remember, if you try to recall, midgut is drained by superior mesenteric vein, hindgut is drained by inferior mesenteric. So Entamoeba in the cecum, they are coming in the superior mesenteric vein, portal vein, liver, and in the liver they can form this abscess. Same with sigmoid colon, beta. Sigmoid colon is inferior mesenteric vein territory, so inferior mesenteric vein opens in the splenic vein, and splenic vein is opening in the portal vein. So portal vein again liver. So whether it is the cecum or the sigmoid colon, Entamoeba can travel through these veins into the liver, and this party inside the liver can lead to a abscess. We can do a ultrasound, but the best would be again CECT of the abdomen. To find out these Entamoebas, we can do stool test for isolation of cyst of Entamoeba. And to kill amoeba, we give metronidazole. Metronidazole, we give 400 to 800 milligram thrice a day into 14 days. ये जो अमीबिक लिवर एब्सेस होते हैं ना बेटा, इनके लिए अपन मेट्रोनिडाजोल देते हैं 400 से 800 मिलीग्राम दिन में 3 बार 14 दिन के लिए. If the abscess is too large, then what we did in pyogenic liver abscess, we do the same story in amoebic liver abscess, that is ultrasound guided percutaneous catheter drainage. The only thing is, in amoebic liver abscess, when we drain this pus, it is a classical anchovy sauce pus or a chocolate color pus is what comes out in amoebic liver abscess. Chocolate color pus, anchovy sauce pus. This is what we see in amoebic liver abscesses. Right, beta? And then there is a hydrated cyst. Hydrated cyst is caused by Echinococcus granulosus. Usually they are single. Patient can present with fever and jaundice. We can do ultrasound, but the best would be CECT. Whenever we are doing ultrasound or CT, then we see a water lily sign. Water lily sign. Water lily sign is seen in hydrated cyst. Drooping lily sign. Drooping lily sign is seen in, yes, duplication of renal pelvis. Right. What is this water lily sign, beta? Herein, if you look at the images what you are having, this is the ultrasound image. The Echinococcus is floating in the fluid, right? Just as a lily flower is floating in the water. So lily flower keeps on floating in the water like this. Same way this Echinococcus is floating inside the cyst. This gives you a water lily sign. These are the ultrasound pictures. These are the CT pictures.
So, process.
Parasite.
Yes. So there's a third lesion over here. It looks more pathognomonic. So this is hepatic and pulmonary hydatid disease. So hydatid disease is caused by Echinococcus granulosis. Most common site of the liver, followed by
Just try to see how this looks like.
Parasite.
Yes. So there's a third lesion over here. It looks more pathognomonic. So this is hepatic and pulmonary hydatid disease. So hydatid disease is caused by Echinococcus granulosis.
Right. So I was just trying to show the movement, how this lily looks like moving. Okay. Now to identify this Echinococcus, the best thing what we can do is a ELISA test, where we detect antibody to the hydrated antigen. And in the treatment for this Echinococcus beta, we are giving the albendazole or mebendazole tablets. Now, one thing which we need to take care when we are dealing with hydrated cyst, and suppose we have to aspirate the hydrated cyst, then we cannot just aspirate like that, because if by chance the hydrated spills inside, then there is risk of dissemination. So what we do is, first we do a aspiration, and then we put hypertonic saline in the cyst so as to destroy any live cyst there, and then we do a re-aspiration, right? So we do a pair for hydrated cyst, that is percutaneous aspiration, then instillation of hypertonic saline, and then re-aspiration. That is how we can manage these hydrated cysts. So pair is mainly done in hydrated cyst. The pyogenic and amoebic liver abscess, they can be drained by just a ultrasound guided percutaneous catheter drainage. Right. The last thing in this right hypochondrium is the sigmoid volvulus. What is the sigmoid volvulus beta? If you just try to take a look. This entire thing what you're seeing is the sigmoid colon.
कोलगेट स्ट्रॉन्ग टीथ हर बार
जैसे गाड़ी का पेट्रोल कम होते जाता है, वैसे ही रोज हमारे दांतों का कैल्शियम भी कम होते जाता है।
कैल्शियम कम कैसे?
दांत जितना चबाते हैं उतना कैल्शियम खोते हैं। कोलगेट स्ट्रॉन्ग टीथ का कैल्शियम बूस्ट दांतों का खोया कैल्शियम लौटा है। कोलगेट स्ट्रॉन्ग टीथ।
Constipation. And is there normally hollow infarction can also cause water. sometimes the mesentery can get so tightly twisted that blood flow to that part of the intestine is cut off, which leads to infarction or death of the.
Basically, what happens here is the sigmoid colon, right? And there is a mesentery of the sigmoid colon. So sometimes what happens? The mesenteric rotation occurs and the sigmoid colon rotates around the mesentery. Especially if the mesentery is quite long, then we can see the sigmoid volvulus.
These X-rays show the shape of the volvulus.
I don't know whether there would be a strike or not. Just a moment, I think. Right, beta. So we are just trying to understand what actually is going to happen here. Here, suppose this is the cecum, this is the ascending colon, this is the transverse colon, this is the descending colon, this is the sigmoid colon here. This is the rectum and this is the anal canal. We know there is a mesentery. And this mesentery is actually carrying the blood vessels which supply blood to the intestine. If suppose the mesentery of the sigmoid colon is quite long, sigmoid colon is relatively a free area in this part of the colon. So what happens? This sigmoid colon just rotates around the mesentery, and when it rotates, it actually moves like this, so that the apex of this sigmoid lies there in the right hypochondrium. Right? That is why we are discussing this sigmoid volvulus, which is in the left iliac. We are talking it in the right hypochondrium, because the apex of this sigmoid moves into the right hypochondrium. So basically, there is a rotation of the sigmoid colon over the long axis of the mesentery. Most common rotation what we see is the anti-clockwise. If it is only more than 180-degree rotation, the chances of obstruction will be high. If more than 360-degree rotation occurs, then the risk of strangulation perforation will be high. Why we are reading this? Because of this MCQ of radiology. On X-ray, we may find a coffee bean sign. We can even find a bird of prey sign. Coffee bean sign or bird of prey sign. In the treatment, it is very simple. We just leave a flatus tube in the sigmoid colon for 24 hours. Now, what is this, beta? Flatus tube is just a catheter. So you just leave a tube into the sigmoid colon like this. Sigmoid colon is actually lying here. Here. So the sigmoid colon is getting distended with fecal impaction, air and everything. Just by leaving a flatus tube in the sigmoid colon for 24 hours, deflates the sigmoid colon. And then it derotates on itself and comes back to the normal location. So generally, just by putting a flatus tube for 24 hours, the story can settle. If by chance there is strangulation, ischemia, perforation in the sigmoid colon, then we have to do resection and anastomosis. These are few images, beta. This is a coffee bean sign, what you are seeing. Can you appreciate how this coffee bean is looking like? The coffee bean. I hope you can make out this. And this is the bird of prey sign, as if the bird is holding its prey inside. So this is the body of the bird, and this is how the bird is holding its prey inside. These can be seen in sigmoid volvulus. So that is all about the story of right hypochondrium. And now what we'll do is we'll call it a day here because we have exceeded the time for today. And today, what all we have discussed, if we just try to summarize the just in brief, and then I would like to take the queries live. Right. So today, or what we discussed right from yesterday, we started with adult surgical problems, where we talked about the stories of dysphagia, the Zenkus diverticulum, the achalasia cardia, the nutcracker, diffuse esophageal spasm, Schatzki's ring, and lie stricture. Then we talked about the surgical chest pain story, GERD, retrosternal pain, complications of GERD, esophagitis, Barrett's, and hiatus hernia story. Then we talked about a Bohr-Harvey syndrome or a barotrauma where there was a rupture of the esophagus. Then we talked about iatrogenic esophageal perforation and foreign bodies in the esophagus. Then we came down into the abdomen in the epigastrium. We talked about stomach and duodenum, the gastritis and the peptic ulcer stories. Gastritis, acute gastritis, char bottle vodka. Chronic gastritis type A and type B, A autoimmune, B bacteria, H pylori. Then special gastritis like Menetriers, erosive, AIDS, eosinophilic, and reflux gastritis. Then we talked about peptic ulcers, the ulcers in the stomach and the duodenum. In these peptic ulcers, we saw the differences between duodenal and gastric ulcers. We saw how to approach these patients of peptic ulcer, what surgeries we can do in duodenal ulcer and gastric ulcer, what can be the complications of these surgeries, what can be the complications of peptic ulcer as such. Then we talked about Bezoar's, Trichophyto, and Lactatobezor, then bariatric surgery. Then we moved into the right hypochondrium, where we talked in detail about the gallbladder stones, why these stones form, how these patients can present, what we do in their treatment depending on how they are presenting to us. Please remember, all the doctors, my dear lovely friends, that your treatment will depend on the patient's presentation. Your treatment in the hospital, when you are working as a doctor, it will not depend on what is written in the workbook or what is written as the definitive treatment of choice for that particular situation. Actually, it depends on the situation of the patient that what treatment should be started first, right? That is why the MCQ people are also continuously focusing that if the patient is coming to you like this, what will be your next step? That means whether you have a clear idea about these things or not. So in gallbladder stones, we talked about the different situations and the different methods of treatment. We talked about other pathologies in the gallbladder like mucocele, empyema, the cholesterosis or strawberry gallbladder, porcelain gallbladder, Mersey's syndrome, fistula of gallbladder. Then we talked about stones in the CBD, choledocholithiasis. Then we talked about acute pancreatitis, chronic pancreatitis. Then some passing reference about liver abscess like pyogenic, amoebic, and hydatid cyst. Then a passing reference for a radiology sign, coffee bean and bird of prey sign about sigmoid volvulus, how sigmoid volvulus can rotate around its mesentery and increases the risk of strangulation and perforation. So we just leave a flatus tube for 24 hours and it deflates, decompresses and derotates on its own. Rarely, if that is strangulated or perforated, then we have to resect the sigmoid colon and do an end-to-end anastomosis. Right, so this is the whole story what we discussed till now in adult surgical problems. Now what we are left with is flank area, where we have to talk about urinary stones, the iliac fossas, appendicitis, inflammatory bowel diseases, hypogastrium, the bladder urethral trauma, and benign prostatic hyperplasia, the groin hernias, then the scrotum, the testicular torsion, varicocele, hydrocele, penile problems, phimosis, paraphimosis, priapism, and rectum anal canal stories, the rectal prolapse, hemorrhoids, then anorectal abscesses, fistula, anal fissure, and pilonidal sinus. So these are the things I think hopefully we should be able to do tomorrow. And now I would be happy, Beta, if I can take up your queries live. So first what I'll do is I'll take a look at the batches. If you have got any query, first I'm looking at the chat section of the batch. Right, so there are no queries as such in the chat section. Now I'll take a look at the WhatsApp and let me start from where I have not responded. Beta, I'm trying my level best to respond to as many queries as possible, but still I feel that I might have missed 5 or 6 queries. So if by chance I have not responded by mistake, please do ping me right now so that I can answer to you right now. Tomorrow, be prepared, beta, that there is some engagement which has come up somewhere between 3 to 6 p.m. In the late afternoon. So I have requested the schedule coordinator ma'am to excuse me between 3 to 6 p.m. time. So we'll be starting by 9 o'clock in the morning and completing by 3 p.m. in the afternoon, and then we'll be restarting maybe around 6 or 6:30. That starting time, you just be careful in the WhatsApp group. If there is any change, I'll request the schedule coordinator ma'am to update the exact timings in the evening. 9 to 3, 99%. We are going at with 9 to 3, and then 6 p.m., 6 to 8 p.m. or 6 to 8:30 p.m. or 6:30 to 8:30 or 9 p.m. That may be updated, beta. Anjali from Dawa in fistula. Anjali from Dawa, beta, in fistula of gallbladder, no need to treat fistula. Nahi, Anjali, you are absolutely correct. We need to treat the fistula, beta. We need to divide the fistula. We need to repair the duodenum, and then we have to do a cholecystectomy. However, what we have written is just an emergency scenario. When the gallstone ileus has developed, when there is an intestinal obstruction, at that point of time, we just relieve the emergency. Fistula is treated later on, after a few weeks or months. Let me save this. Krishna, beta, please mention your university also so that I can save it properly. In fistula of gallbladder, terminal ileum is obstructed due to, but fistula most commonly occurs in first part and there is sphincter of Oddi in second part. No, beta, sphincter of Oddi is in the side wall. It is not in the lumen. Sphincter of Oddi is actually guarding the CBD and pancreatic duct opening, which are in the side wall, in the medial wall of second part of duodenum. So sphincter of Oddi is not present in the lumen of the duodenum. It is present on the side wall of second part of duodenum, on the medial wall. Chanchal from Kagyan. Could you please solve question 2, page number 114? Page number 114. Oh, okay. Chanchal, beta ji, today I think when we have done with the peptic ulcer, then you might have come to know that in peptic ulcer, stenosis is one of the complications in peptic ulcer, right? So if there is a stenosis of the peptic ulcer, you have also seen the common sites of peptic ulcer. First part of duodenum and then lesser curvature of the stomach close to the pylorus. So just imagine beta, if there is stenosis near the pylorus, it can cause a pyloric obstruction. So even a peptic ulcer when heals by fibrosis can cause pyloric obstruction. And whatever cause is there, if there is a traffic jam at the pylorus, the proximal stomach is going to get distended and dilated. Patient will present with non-bilious vomiting. There will be metabolic alkalosis. There will be paradoxical aciduria also. In case of small babies, pyloric obstruction is commonly related to congenital or infantile hypertrophic pyloric stenosis. In case of adults, it is generally related to peptic ulcer disease healing by fibrosis. And in elderly people, 60-70 years old, this cancer inside the stomach can cause pyloric obstruction. So now if you look at this question number 2 beta, this is a 55-year-old male, right? And in the question, he presented with repeated episodes of epigastric pain for the last 3 years. Initially, he was getting relief by PPIs. That means this was a clear-cut case of peptic ulcer. Later on, he took eradication therapy. So again, he's telling peptic ulcer story. Now he's not getting any relief. For the last 6 days, he's having non-bilious projectile vomiting. He is not giving history of significant weight loss in the recent times. So cancer is ruled out. Age of the patient rules out hypertrophic pyloric stenosis. Hypertrophic pyloric stenosis occurs at 17-day-old, 3rd week of life. जिंदगी के तीसरे हफ्ते में जब बच्चा बिल्कुल छोटू सा है, right? So I hope this helps, Chanchal. With the last 5 digits 77567. Please do mention your name and university. I think I have not added you in my contacts. The difference between reflux gastritis and GRD. Beta, GRD is esophagitis due to reflux of gastric contents in the esophagus, and that can occur when there is damage to lower esophageal sphincter. While reflux gastritis is reflux of jejunal or duodenal contents into the stomach. That can occur whenever there is any damage to the pyloric sphincter. So moral of the story, lower esophageal sphincter damage, reflux of stomach contents into the lower esophagus, reflux esophagitis or GRD. If the pyloric sphincter is damaged, reflux of duodenal or jejunal contents into the stomach, that is reflux gastritis. I hope this helps, beta. Yeah, we have to do LFT, beta. Tara from Bogomolets. We have to do LFT if the patient is presenting with jaundice. The first investigation in a patient presenting with jaundice will always be LFT, beta. Sandeep from Harbin, beta. Why can't we use shockwave in stones of gallbladder CBD? The shockwaves, beta, the problem is the diameters. Like if there is a stone in the gallbladder, then diameter of cystic duct is 1 to 3 millimeter. And even if you are using shock wave, beta, by shock waves, you will be breaking the stone to not less than 1 millimeter in size. So there are chances that these stones may get stuck and create more complications. Plus shock waves if you give repeated shock waves, it can create more damage than good. Thank you so very much, Rusha Beta. Is the risk of bacterial growth in the synovial accumulation? Yes, that is how abscess can occur in the pseudocyst, Beta. Please do mention your name and university, Beta. Last 5 digits 45627. My doubt is how much chance of reoccurrence reflux after Billroth 1 and Billroth 2. Generally, the chances of reflux after Billroth 2 are high. The reason for modification of Billroth 2 into a Roux and Y gastrojejunostomy is we try to create a long limb of the jejunum so as to avoid the reflux of biliary contents. So the chances of reflux gastritis are very high. Urmila from Odessa, if we do sleeve gastrectomy, will the patient suffer from pernicious anemia? Yes, the patient will suffer from pernicious anemia if we are doing a sleeve gastrectomy. Ragul from Venezia, Beta, in pseudocyst of pancreas, if it enlarges more, if after we remove the stone or in presence of stone it enlarges, why does it doesn't pass through duct? That is probably because the stone might have caused some injury at the duct site. So there might be some edema or sometimes stricture may develop in the pancreatic duct at the stone site. That is why the pseudocyst is not able to resolve. That secretion of large amount of fluid by the peritoneum is in any condition, wherever there is any inflammatory activity taking place, the secretory surfaces, they try to produce more and more fluid, secrete more and more fluid to neutralize that particular area. So ascites and all that, once the story subsides, then they will also subside with time. If the ascites is huge, then we have to do a ascitic tap as well. Priya from Davao, how about cholestasis is more common in pregnancy? What is the cause? Beta, in pregnancy, we can understand what is happening. The hormonal changes, number one, because of those hormones, the motility of the gallbladder decreases, right? The motor movements of the gallbladder decreases. So that leads to cholestasis. Plus, obviously, in later months of pregnancy, when the baby is occupying the big uterus, the uterus might be pressing on the biliary channels as well, which is not allowing the bile to flow nicely. Tan Singh from Orenburg, Namaste Beta ji, मैं अच्छा हूँ. Sir, when we are doing GJ, then we have high risk of adenocarcinoma. What we have to do so that we cannot do anything better to minimize the risk of gastric cancer if we are doing a gastrojejunostomy. हम एक बीमारी को ठीक करते दूसरी बीमारी को इनवाइट कर रहे हैं. बहुत बढ़िया थान, बहुत अच्छा लगा ये जान के, क्योंकि आई थिंक इफ somebody is listening apart from Tan Singh, then surgery is something which is taken as a last resort, beta. When no medicine, nothing is helping, then only we are doing surgery. Because even if you are doing a small surgery, there will be some or the other complications. At least that surgery is going to leave a scar in the patient, है ना? निशान तो देगा ही कम से कम, कोई भी ऑपरेशन अपन करते हैं. So surgery is only done in those situations when we weigh the pros and cons. That if we don't do surgery, will the patient be having more benefit or more risk? If we are confident that if we don't do surgery, then patient is having more risk, then only we are going to do the surgery. Dhanush from Volgograd, beta, in esophageal atresia, does the trachea remains connected to the esophagus after finding out the congestion? Do we allow the trachea to remain while we wait for two? Yeah, we allow the trachea to remain connected to the esophagus in the 4 to 6 weeks period, because we are anyways doing a feeding jejunostomy. So the chances of reflux into the trachea would be extremely low. Kannan from Dali, beta, you are having a doubt regarding this question, let me have a look at the question. Kannan beta, this is the question where he's saying that the pain is there in the right gluteal buttock and thigh region, right? Claudication is there. And right lower limb, no pulses are palpable, but left lower limb, all the pulses are palpable, right? What does this mean? If you just take a look at the aorta beta, it divides into two common iliac, and then common iliac divides into internal and external iliac. Just imagine that if one side pulses are normal, that means the obstruction cannot be at the level of aortoiliac region, because if there would have been a traffic jam at the aortoiliac, then the pulses in both the lower limbs would have been absent. If only one lower limb story is mentioned, that means the story should be somewhere either in one of the common iliacs or maybe the external iliac on one side. So herein, iliac obstruction can be a better answer, because femoral is also not palpable. So there has to be a traffic jam between the femoral and the aorta. That is the right common iliac or maybe the right external iliac. Pooja from Usgrowth beta, very good evening to you beta. Sir, in bariatric surgery we do Roux-en-Y gastric bypass. After weight loss, patient will not suffer from nutritional deficiencies. Patients suffer from nutritional deficiencies a lot beta after bariatric surgery. They suffer from nutritional deficiencies. But we are doing this procedure because this is a patient whose knees are not able to tolerate the weight, who might have had 4 or 5 stents in the coronary artery. Right, so we have to just weigh the risk and benefits. Vagus nerve concept in peptic ulcer beta. Vagus nerve is basically having two type of fibers: secretory fibers, the nerves of Grassi, and the motor fibers, the nerves of Letarsett. The secretory fibers are supplying the parietal cells and stimulate the parietal cell to secrete HCl. So whenever we want to have a acid control, we should chop the secretory fibers, that is nerves of Grassi, that is a highly selective vagotomy or a parietal cell vagotomy. But sometimes earlier when we were chopping the vagal trunk or the selective vagotomy, then we also were chopping the motor fibers along with the secretory. So if motor fibers are gone, then the motor movements of the stomach will not occur, and this will lead to gastric stasis. Vignesh from Davao, how will alcohol cause acute appendicitis? Alcohol will directly not cause acute appendicitis. If the patient remains constipated, then fecal ball can block the mouth of the appendix, and that can cause acute appendicitis. Hana from Yerevan State Medical University, Armenia. Murphy's sign is seen only in emergency and not OPD. Then when do we see Mussi's and Ortner's? Can you specify these Mussi's and Ortner's signs, Hana? Sheikh Kamran from UNP beta. Which drugs do we use in H. pylori eradication therapy? Beta, there are different combinations which can be used. Like we can use the amoxicillin metronidazole combination. We can use clarithromycin metronidazole combination along with proton pump inhibitors. Parth from Bicol Beta, regarding the Telegram use, I'll do something for surgery questions on Telegram. I'll request someone to do that. Abhinav from Our Lady of Fatima, Philippines. Very good evening to you, Beta. For pseudocyst, you have mentioned that if the patient is symptom and then we do internal name of cystoenterostomy. Isn't it should be pseudocystoenterostomy? Great, Abhinav. I think that's a wonderful correction. And I think we should advise the authors. You are absolutely correct. Ideally, it should be pseudocystoenterostomy. Why we are using cystoenterostomy there? Great, good. Rushabh from Davao, if there is risk of active wound, internal drainage, pseudocyst complication in a patient. Beta, we are not doing internal drainage, Rushabh, for a abscess. If there is a abscess, we just do external drainage. But if it is not an abscess, then we are simply doing a internal drainage. Yes, RF from Sumi, in case of trichobazor, can we use endoscopic method or we have to do laparotomy? Nowadays, no laparotomy is needed. We can remove the hairs endoscopically. Abhiti from Davao, pseudocyst can cause, so why do we? I hope you got it, Abhiti. If there is an infected pseudocyst, then we do external drainage. But what we discussed, internal drainage, that is when the cyst is non-infected. Ilya from MCU, Philippines. What is this MCU University? Please do mention, Beta. And you have given the question on page 62, question number 1. Let me just check. Page number 62. Patient presenting with pain in the thigh and the leg on the right side. Aggravated on walking exercise. Popliteal distal pulse is absent. Left lower limb normal. Brew femoral artery. See, Beta, in this particular case, in the right lower limb, the popliteal and tibial are gone. That means the obstruction has to be just above the popliteal. Now, femoral artery, you are hearing a brew. And where do we palpate the femoral artery, or where we do auscultate to the femoral artery? Just beneath the groin crease. And it is after mid-thigh that femoral becomes popliteal. So if popliteal is gone, obstruction is proximal to the lower thigh level. If you are able to palpate, if you are able to hear a brew over the femoral artery just beneath the groin, that means there has to be obstruction between the groin area and the lower thigh. So this becomes the distal femoral. That is why femoral arterial obstruction is the answer for this question. Murari from 1st August, beta, please do mention your university. Murari beta, we will be doing these classes again later on, but yes, if you have requested, I'll send the request to the team and we'll try to get it done. But let me tell you beta, 7th, 8th, 9th, you are having long classes of microbiology. Seth, may I know what is DSMU? How does gallstone cross the sphincter of pancreas in acute pancreatitis? When the bile is flowing with pressure in the CBD, then because of the pressure of bile, many times the gallstone that forces the fibers of the sphincter damages the sphincter fibers and comes into the duodenum. Highly from NSMU, or what if we do cystogenostomy and at one point the cyst resolve? The cyst is going to resolve as soon as you put it in the, connect it in the jejunum beta, because now the secretions will not remain, the cyst will not remain. That is just going to resolve into the jejunum. If you don't do a cystogenostomy, Ailey, then what will happen? The cyst will keep on enlarging. So we have to connect those secretions somewhere, no? Kishore from Orenburg, in live stricture to provide food, can we insert nasogastric tube? No beta, we prefer doing a feeding gastrostomy or a feeding jejunostomy there. In barium swallow, if case we don't know about perforation, we did barium or chewed. To avoid complications beta, it's better that if there is any suspicion, we avoid using barium or we dilute the barium a little more so that it causes less risk. Thank you, Samrat. Thanks a lot, beta. May God bless you. Moose's and Ortner's and acute calculus cholecystitis, Hannah. Moose's is pain by pressing between peduncles of sternocleidomastoid muscle. Peduncles of SCM muscles. Hotness, increased pain on percussion in right costal margin. If you try to irritate the gallbladder, you can see these signs. But to be honest, Hannah, let me just share this, that I have not read these Moses and hotness sign. So I'm not pretty sure about this. AP and PA view, beta. I think your radiology sir would be a much better person, and let me not confuse you there. So I think he would be a better person to explain you the AP and PA views in X-ray. Okay, thank you, Ilya. Thank you, beta. Thank you so much. Bashir from ISM, beta. What is the meaning of cyst? Cyst is simply a collection of secretions. In hydrated, why can't we clear obstruction in pancreatic duct so it will excrete enzyme normally in intestine? In pseudocyst, I hope you are trying to say. Beta, pseudocyst is developing only when we are not able to clear the obstruction, because the diameter of the pancreatic duct is very less. So many a times it is difficult to pass any endoscope or anything into that tiny pancreatic duct. We are not able to clear the duct obstruction, Bashir. That is why we are doing the connection of the pseudocyst with the intestine. I hope this helps, Bashir. No more queries, beta. Thank you very much for your patience. May God bless you all. May God give you all the strength and courage to fight it out. May you remain pumped up, and may you all come out with flying colors. Good night. God bless. See you tomorrow morning, 9 o'clock. Bye-bye.